Right, good morning and welcome. So it is Thursday, summer holidays. We're doing a day-to-day with nursing and midwifery. You can see the screen. Okay, this is Mid and South Essex that are helping us put this on today. And we're looking at nursing and midwifery, which is quite interesting because midwifery is something that I'm still learning more about, which excites me, because obviously it's not an area that I would naturally know about, but we're learning more. And we are talking about nursing and midwifery today. We are Pathway CTM. We're hosting a session, like I said, on behalf of Mid and South Essex. That's the important part. When we're looking through today, I'm the host. I'm not the important part today. Everybody, all my guests that are coming to speak, they're all the important parts. I just hold everything together. So with that, what we need to think about is how are you going to communicate during the webinar? Well, I've had lots of people putting stuff in the chat box. Hopefully you've got comfortable with it. You can see where it is. You know what you're doing. Let's use that chat box, okay? You can raise your hand if you want. I know not everybody is confident doing that, and it doesn't always work. We don't always have a microphone that works, but I would encourage you to start thinking about getting these things in place. But use that chat box. We will ask you questions and we will put questions in. Lots of stuff is going to be shared, lots of information going back and forth, okay? And there's still some people putting some good mornings in the chat box, so please reply to them if you wish. So who am I? I did say I'm not the important part of today. My job today is to make sure that everything runs together. I keep an eye on the chat box. I move the sessions along nicely. And I'm the head of student success. So I look after events and student success at Pathway CTM. What does that mean? We do days like today to open up opportunities to students like yourselves to learn about new areas. And you might be thinking, I'm not really sure about this area, or I want to know more. And we might present something to you today that you didn't know about or give you more information about it. You don't need to act on that right now. Absorb the information today and then go away and think about it. When you go away and think about it and you're like, what do I do now? Session's over. Who do I ask? That's my student success part. Me and my team, we look after students. Every Wednesday, 4:30 till 5:30, I do a drop-in session. That drop-in session is for students like yourselves who just want to ask questions or need support, help, applying, finding resources, getting things done. Okay, so that's what I'm there for. That's what the student success part is about. So don't be shy in coming forward. I also I do events like today so that we can get that information across, and it helps me learn so I can give you better information. And as I said, I just look after today and make sure that all my guests are welcomed and they've got the best forum to be able to speak and give the information they need to give, which we're going to need in a minute. But before we go any further, I'm going to launch a poll. 2 simple questions because we've got a lot of this interaction going on. So just 2 simple questions to start with this morning. Okay, so you'll see the poll on your screen. How much do you know about nursing and midwifery? So you can say, I know just a little bit, I know a fair amount, but I want to learn more. Or I know pretty much everything there is to know, but you can always learn more. Or I'm an expert. And then what route are you considering after school or college? Apprenticeship, university, not sure yet, maybe a gap year. If you choose other, put it in the box for me. Okay. I'll give you another 30-ish seconds to answer that. Almost there. Another 15 seconds. So what route are you considering after school or college? Apprenticeship, university, not sure, gap year. And then how much do you know about nursing and midwifery? You know a little bit? Do you know a fair amount? Do you know pretty much everything there is to know, but you can always learn more? Okay. I am going to end that poll. Let's share those results. So what we're looking at, 24% know just a little bit, 74% know a fair amount but want to learn more. We've got 3% who know pretty much everything there is to know. Oh, I'd like to know who you are. Nobody's an expert, which is good. But those that know just a little bit and those that know a fair amount, that's the whole point of today. Come and open your minds and listen and absorb the information. It will be, today is being recorded as well, remember, so you can revisit the recording next week once it goes up on the website. And if your parents are interested in what your future options are and you're talking to them about this, they can watch the recording as well. They can come to today if they want. But also if you've got friends who are interested in this too, you can say, hey, why don't you go and check out that session that I was on? It's recorded, it's on the website. And then what route are you considering after school or college? 6% say apprenticeship, 76% say university, 12% are not sure yet. Great. Those that are not sure, you're in the right place. Again, open your minds and listen to the information and use the resources to make the best decisions. 6% say gap year. And again, I think that's a great opportunity, especially if you're going to go on to an apprenticeship. Okay, because you're still getting into real work quicker than you would if you went to university. So brilliant. Let's have a look. With that apprenticeship and university stuff, we are going to be doing some sections about routes in university versus apprenticeship. And it's not about saying one is better than the other. It's about opening those choices for you so that you can do what you think is right for you, but you've got the best information for it. So when we look at today, we've done the sessions. We've got an introduction to nursing and midwifery first and looking at the different pathways in, and we've got 2 guest speakers speaking about that with slides. Then we're going to be doing speed meets from 11:05 till midday. And those speed meets, I've got 4 people. I've got Alex, Ellie, Rebecca, and John. And we're going to be meeting them, asking lots of questions. Okay. Finding out about what they do, and they'll be telling us about that as well, which will spark questions. And be free to ask questions. Then we go for lunch 12 till 1. Then in the afternoon, we've got activities. So we're looking at, again, nursing and midwifery activities, maybe some case studies, maybe some activities. And Tash will be back for that in the afternoon, along with Alex. So actually, 2 of the morning speakers are back in the afternoon, Alex and Tash. And then we've got the Q&A, the final Q&A of the day. But I like to always think that I could get to that Q&A with not as many questions, because we'll answer a lot through the day. So don't be shy in asking questions. Now, time for me to make sure I know how to use technology. We're going to do 2 word clouds. We are going to do 2 word clouds. Let's have a look at the first one. So what you need to do is, let me get this across to the right screen. Okay, I need you to go to menti.com, put in that code. So you can do it on your mobile phone. You can do it on your Explorer now, as in your internet thing. It's not called Explorer anymore. But yeah, you go to menti.com and put in that code 867127773. I'm going to do the same, make sure it works. So 27773. Perfect. So how do you think you become a nurse? Okay. Apprenticeship, university. Keep putting words in. And it doesn't matter if somebody else has already put those words in. I want you to put in the words that you think go in. Okay, so keep putting information in. Keep putting that information in. Let's see what we get. So what we're seeing there, we've got, like, you're looking at good personal statements, live webinars, wanting to help people, practical work experience, degree, college, university, apprenticeship, again, work experience, degree, apprenticeship, support worker, courses, college, placements, practice, care certificate. Okay, so we've got lots of information coming in and lots of ideas about how do we become a nurse. And that's what we're going to learn about today. I'm not going to give you an answer now. We're going to find out throughout the day. What do we think? Okay, there's still answers coming in, which is brilliant. The bigger words are the ones that are mentioned more often as well, so which is brilliant. We've got lots of ideas as well. So hopefully this is opening your mind that there's not just one way in. There's lots of different ways in. And we're going to explore those further. What are those different ways in? How do they work? Why do they exist? What's the point of the different routes in existing? Why do they exist? Surely it should be just one route, no? But we'll open your mind. Okay, so that's how we think about becoming a nurse. Medical school, you start at the bottom. Midwifery degree, practical work, you register. Okay, we've got entry courses, lots of bits about the experience and the work experience and going to college and university, degrees. And I love the fact that we've got the apprenticeship popping up a few times as well, degree apprenticeship popping up a few times as well. And yeah, think about your qualities. You know, being a support worker, fantastic. Right, we've got one more. We close the voting on that one. Let's move to the next one. What are the different types of nursing then? Tell me, what are the different types of nursing? Are there different types of nursing? Is it just one? Let's get them in. What do we think? Okay. I'm going to give extra marks for the bravery for whoever is putting pediatric in, because that's not the easiest to spell in my book. Okay, so what we got? We got community, pediatric, midwifery, physical health, geriatric, child nursing, neonatal, mental health, adult, children, peds, which is pediatric, neonatal again, community, primary care, physical health, dental, baby nurses, acute care. Ooh, keep it coming. Children, palliative, geriatric, learning disabilities, oncology nurse. Brilliant. We've got a few more coming in. The big ones are mental health, adult and children. We've got dental as well. Midwifery is in there. We're talking about that today. We're meeting them. We're going to be meeting them. Okay. Let's close the voting on that. Brilliant. So we can see the words there, learning disability as well. Neurosurgeon, good one. I like it. So let's move on with today then. I've done enough talking. We've set the session. We've got ideas about how do we get into nursing. Let's find out more. We've had a look at the different types of nursing and midwifery as well. Let's find out more. Today, like I said, I'm not the main event. I'm going to introduce you to two main events. We've got Tash and Amy who are going to speak to us. I'm going to meet Tash first, and Tash is going to take us through nursing and midwifery, and then Amy is going to follow afterwards, and Amy is going to take us through alternative routes in. So good morning, Tash. How are you?
I'm fine, thank you. Thanks a lot, Max. As I say, I'm Tash Morrison. I work across the Mid and South Essex group. I work as an education facilitator, which means we support nursing midwives through their clinical placements. Previous to this role, I did 13 years within the university teaching nursing, and my background obviously is a nurse. I'm a registered nurse, and I also work in general practice at the moment, but I've got a background as a ward manager on a surgical ward, worked in high dependency units, and that's a little bit about me. So that's why I'm here today, to sort of share a little bit of knowledge that we've had. So yeah, let's get on with it. I'm gonna focus on from the university sort of side of things, how to do that entry into nursing and midwifery, and then my colleague Amy is going to follow up with that apprenticeship style route. So we will gloss over a couple of these slides to make sure that we don't sort of duplicate anything and you get a bit bored, and we don't want that. But also it's just so I don't steal Amy's slides or anything like that, because we don't want that either. Okay, so do you want to pass on to the next slide? Lovely, thank you. The first thing we want to talk about is about nursing. Nursing is not just something that we just come up with and think, oh, I want to be a nurse. We're actually a regulated, nursing midwifery is a regulated profession. And what we are regulated, so the government actually, there is laws around who can be nursing and midwife, and also around what we can do as nurses and midwife, and how we train and things like that. So we have a UK regulatory body known as the Nursing and Midwifery Council, and that responsibility of that organisation is set out in law. Now, their primary focus is actually to protect the public. It doesn't protect nurses. It's making sure that the patients and women that we look after as nurses and midwives, that we make sure that we actually sort of follow the right guidance, we follow the right procedures, and that we actually do things correctly and supportively for our patients. They regulate nursing, midwifery and specialist nursing roles, all the different types of community public health nurses, so things like health visiting, school nurses and community nursing. They charge an annual fee to people that are registered, like myself, and I think Alex is on the call at the moment as well, and she's a registered midwife, so we have to pay our money as an annual fee. But most importantly, this body of people make sure that the universities, so the higher education institutes, deliver the right things to make sure you, if you were going on to this pathway, that they make sure that you are delivered and you're learning and experiencing the right things to ensure that you can look after patients correctly, effectively and safely. Thank you. Next slide. So one of the things you have to think about, you know, you're all sort of teenagers, 20, sort of heading on to out of your teenage years, is about what your perception is of nurses. Now, I know definitely that most of you won't recognise that picture on the right hand side of the two nurses in their frilly hats and something, but there's a public perception that we have to think about what it is nursing and midwifery and what it's not. So one of the things, you know, if anyone wants to be really clever, who is this individual in the middle here, this picture? You can pop it into your chat. I'll give you an opportunity to wake up. So pop it into the chat for me. Who is that in the middle there? Absolutely. So very good. Is that, and so I was first, I think, into the chat. So yes, absolutely. That's Florence Nightingale. So anybody want to be really clever and tell me who these people are on the right hand side? You have to be quite old like myself to actually know who these are, but some of you may have families that who like to watch these types of films. Anybody know?
I did have a type of film in my head. I'm not going to say anything, so I'll leave it to them.
Not quite the Call the Midwife ladies.
But then I'll wait and see what you said.
Yeah. Okay, Max, you can have a go. Who do you think they are?
Are you going to savage me if I say it? They look like they're two characters from Carry On films.
They most certainly are the two characters from the Carry On films. Absolutely, well done, excellent, Alaya and Leslie. Yes, they're from the Carry On films. So, you know, there are public perceptions of what we think about as a nurses, and there is a little bit of a public perception that we're people that wander around and we sort of mop someone's brow and we have our frilly hats on and things like that. And Florence Nightingale, obviously, epitome of where the nursing profession starts from, but she's not in isolation. There are many other individuals that have shaped nursing. You know, one of the people that really shapes nursing for me is Mary Seacole, and other type people like Edith Cavell. There was lots of different people that have shaped nursing to what it is today. But you know, nurses being angels, I don't have wings. Okay, I'm not an angel as such, but we sometimes need to think about what the public perception is of what nurses are, and sometimes that can be a bit challenging for us because I'm not someone that wanders around with a frilly hat, and we're going to talk about what nursing is and what it's not as we go through the slides. So if we want to go on to the next slide, Max. So the reality of nursing, we are highly educated individuals, we're highly educated professionals, and with a diverse role in diverse settings. So to give you a little bit of a background, I will talk a little bit more about it. Over the period of time that I've been a nurse, I qualified as a nurse in 1996, obviously well before you were born. But in that time, I've worked with patients in, as you said, high dependency, surgical wards, been a ward manager. I've had the opportunity to nurse abroad. I've had the opportunity to nurse in different places. I've used my nursing outside of my job. I'm a scout leader and I'm always the first aider on camp. So I've always been able to use my education and my role as a nurse in all different aspects of my life. And even now I work in an education role I would never, at 18 years old, thought, well, that's what I'm going to become. So it's really diverse and it can take you all over the world. And that's the reality of it. Is the fact that we're highly educated. Now, the difference is you will hear some public perception around, oh, nurses, you just go and learn, you know, whilst you don't really need a degree. And someone actually said that to me about 3 or 4 years ago. Nursing midwifery, registered nursing midwifery is a degree profession. It is a graduate profession. So it means that you do need a degree. And what has actually found that degree level education saves patient lives. For every 10% increase in nurses with degrees, it associated with a 7% reduction in the mortality rate of patients. Okay, so it means that tells us that you have to be knowledgeable and educated to be a nurse, and that's sometimes where we challenge public perception. So it's no different than if you went down a physiotherapy route, occupational therapy. There is still that degree education that you undertake to become a registered nurse or midwife. Go to the next slide, Max. I feel like Professor, Chris Whitty for the COVID
Yeah.
this morning. So we're going to talk first about the BSc route. There are still some odd education institutions across the country, not in this area, that do a BA in nursing that you will find. But most of these courses do carry on to be registered as to enable you to qualify with the Nursing Midwifery Council as a registered nurse. So we have adult child mental health, and I don't know why the learning disabilities has been not on the side. There is learning disabilities nursing as well. There is also what we call dual registration awards that are starting to emerge again, which is where you go on a longer program where you study adult and mental health or child and mental health. So there's a conjoint registration. So you could register as both an adult nurse and a mental health nurse with the Nursing Midwifery Council. Okay, next slide, please. So the routes into nursing is quite a busy slide here that's been taken off. There are lots of different university options. Now, some of them I'm obviously going to leave the apprenticeship sort of style route alone at the moment and leave that for Amy. But the most common way we're seeing at the moment is this route to becoming sort of a single registered adult nurse, child nurse, mental health nurse. And what happens is the entry level to actually undertake that degree program would be a level 3 qualification, and we'll talk about the qualifications I think in the next slide. But you have that 3-year degree, that very traditional style training where you go into a university, you have a mixture of clinical placements and university study, sort of normally in blocks. You then obviously are awarded a degree, a BSc Honours in Nursing, and it obviously allows you to register as a nurse or a midwife, in this case as a nurse, and you will enter the NHS. Most people enter the NHS at starting salary at a band 5. That's sort of a common route. There's obviously a 4-year degree that is that dual registration between adult and mental health or child and mental health. Once again, leading to that degree award and starting salary at an NHS pay band 5. I say that most people go into the NHS. Most people do go into the NHS, but with the changing NHS services, we have got other providers that actually provide services on behalf of the NHS. So you may work for a different organisation that might not necessarily be the NHS. There's also a route of becoming a nursing associate. And I know, Amy, you're going to cover nursing associate, aren't you? Yes, so I'm not going to talk about it. So it's a very different role, but it actually is a foundation degree. And obviously you can then go on to a pathway after being a nursing associate to be a registered nurse. And then there is a sort of a route to becoming where you do a 2-year foundation degree and you top up to a degree. And I'm not going to talk too much about that because Amy might get upset with me. Okay, so if you want to do the next slide. So registered nurses are what we call autonomous practitioners. Who knows what autonomous means? What does autonomous mean?
Stick it in the chat box. What does autonomous mean?
What does autonomous mean? I'm sure I thought it was a type of car that you had, license you had when I first saw it. What does autonomous mean? Oh, excellent. Thank you, Kate, for your honesty. That's really good, because actually it's really good to be honest that you don't know. So yeah, so autonomous means that you are accountable and you work within your scope of practice as an autonomous person. So you're making decisions about the patients in your care. Now, that decisions may be directed from other members of the team, but you are an autonomous practitioner as a registered nurse. And it means you're accountable for your actions and your omissions. So the things you do and the things that you don't, you omit to do. So, okay, so not just the things that we do, but the things we don't do. And a registered nurse provides and evaluates care. They lead and manage teams, and they assess, plan and manage and evaluate patient care. Now, I'm not going to talk too much about patient care because we're going to talk about that this afternoon in my session this afternoon, but that's the overarching things that a registered nurse does. Next slide. So your entry requirements are normally around 96 to 128 UCAS points. That is very dependent on the educational institution that you apply for UCAS to. It will be slightly different depending on what university that you have choose to go to. And I strongly recommend when you are looking at universities, don't just look at the UCAS points or anything like that. See how you feel. Now, that's been very difficult to ascertain during COVID, especially those of you that have applied to UCAS this year. Some of the universities have still carried on doing virtual open days, but sometimes it depends on how you feel in an organisation. So I just know locally for us, we've got one very, very big nursing provider and one slightly smaller campus that provides nursing. So it depends what feel that you want. Okay. So it says here about the UCAS points. Someone's put in the chat here, what are the UCAS points requirements for BTEC subjects? Well, where I used to work, we used to ask for a DDM at first, so your MDD in the level 3. However, then we changed it to M's merits, and it just depends on what it is. I would always say apply and not to worry. That would be my individual advice. If you're doing the BTEC Health and Social Care level 3, you apply anyway, okay, because there was always room and scope for movement on that in the process. So I hope that answered your question there, Isabella. We ask for normally around 5 GCSEs at least in English, Maths and Science, and we like them to be grade 4 and above. Now, the English and Maths are the important ones to have grade 4 and above because it's a Nursing and Midwifery Council requirement for you to have your English and Maths, okay, to enter a programme. And obviously you have some form of interview for most higher education institutes for nursing, and that's because it's not just about the GCSEs, it's about you assessing your motivation, how you feel about it, and those sorts of things, and to make sure we've got those that care, that compassion, because we don't ask you to be an expert in biology, we can teach you all that, but it's about having those prerequisites, the things that make you the person you are, is what shines through at an interview. Okay, so you want to move on? So these are the registered course, sort of the stats. Degree level course, 3 or 4 years long, depending on what route you take. NMC requirement of 50% theory and 50% clinical practice. That means that half your time is going to be in a university base. That might be face-to-face, it might be blended, it might be virtual. And then 50% of your time will be in clinical practice. And that is working on clinical areas, supporting patient care, and at the same time learning. You have a mixture of acute hospital and community placements, and you're usually in for about 45 weeks per year. This is the thing that normally makes most of you who don't have a lot of idea of what you're doing to gasp, because your friends that will be taking history, your friends that will be taking geography, will be home by May normally, and won't be going back till October. The university year for registered nurses and actually midwives is a long year. It's normally about 45 weeks. So it's important that you recognise you're not going to have that long summer off. There will be breaks intermittently through the programme, and I hope that doesn't put you off, but it's because we have to get this large amount of clinical practice and experience into your programmes. So Max, next slide. On qualification, the important bit, what am I going to do? On band 5 currently is 25,000, 25,500, and there is rapid progression in nursing. There are so many different opportunities. I even said myself, a moment ago, the opportunities that I've had, we are in an era where nursing is evolving. The future nurse was redeveloped. They threw nursing on its head a couple of years ago to look at what the future nurse would look like, and the future nurse looks very different to the nurse now. Future nurse is in advancing practice, looking at management and leadership, going into research and education. Those roles are more available to people, and the future nurse curriculum has allowed people to be more skilled. So just an example, people that undertake their nursing training or their nursing programs right now will be what's called prescriber ready, which means you'll be ready at the point of qualification to enter a prescribing course. Now, say 5-10 years ago, prescribing was very much an advanced role. It was very much only certain people went on it. It was irrelevant, and we have shifted that now. So it is a much more rapid progression in nursing as we're moving forward, and it's a really exciting time to be entering the nursing and midwifery professions. Okay, next slide. So lots of careers. I'm not going to insult your intelligence here. There are lots of places that you can look. I'm just going to highlight a few within these. Things like working adult nursing, working in things like prisons, working in industry, okay, working in occupational health. So, for example, there are nurses that are working, for example, I'm based near Tilbury in Essex. There are nurses that will be working in the docks. Now, they won't be moving the doc stuff all over the place. They will be looking after the health and welfare of the large amount of employees in a very risky environment working at the docks in Tilbury. So it's not the fact that everybody works on that traditional view of a ward with lots of different aspects you can go into. Cruise ships, mental health nursing, working within general hospitals as a mental health nurse, working with early intervention teams, looking at prisons, children's services. It's not just about that inpatient experience. And I think it's really important that you recognise it isn't just about working in one place. Yep. So does urgent care come under working in A&E? It depends on what services that area is providing. So urgent care in some areas comes under the community services because they're trying to avoid admissions. So things like that. But urgent care in a lot of areas also comes under as a subsidiary of A&E. So we have things like ambulatory care units here. I work at Basildon at the moment. I'm on site here. And that urgent care, it comes under ambulatory centres, and that is actually trying to avoid people going into A&E, so they get directly referred into there. But you might find urgent care in more rural areas. So if you were living in Norfolk and Suffolk, their urgent care might come under the community services because they are miles from the nearest hospital. So it all depends on what that comes under. But it's a really good question, Isabella, really good question. Next slide. Nursing associate. Bridging the Gap foundation degree. I'm going to go next slide because you've got this on your presentation, haven't you, Amy? And have you got this?
I don't think I have this one.
Okay, so what is just a little bit of a difference between the two, nursing associates and registered nurse? Now, nursing associate has lower entry requirements and is delivered as a direct entry route. So you can apply to a university to undertake a nursing associate, or you can go in through an apprenticeship route. We're quite familiar, myself and Amy, with an apprenticeship route for nursing associate because that's where we work. The difference between the two roles is around the nursing associate tends to provide and monitor care, and the registered nurse is evaluating and planning and leading and managing patient care. So they are contributed to this integrating care where the registered nurse, they're both accountable professionals, very much leads and manages that patient care. And that's for you at this stage, what you need to see, that difference between the nursing associate and the registered nurse. Next slide. Entry requirements. Next slide. And Amy's covering that. I know she is. And again, she's covering that. Right, careers in nursing associate in exactly the same way as the last slide we saw. They work in all over the place. Nursing associate is really, really exciting. Taking it out of the acute trusts, there is lots of evolving roles in nursing associates because they can work in any scope of practice in any field of nursing. So it's really an exciting role. So yeah, I'm not going to go into it too much because Amy's going to cover it next. Next slide. So I'm going to talk a little bit about midwifery. I know Alex in her presentation is going to be talking about the role of the midwife as well as talking about case studies. And the registered midwife provides care to women, newborn infants and their families. So trying to sort of challenge that public perception of midwifery. It isn't wandering around sort of cuddling babies as such. It's that holistic pregnancy care from pre-pregnancy through pregnancy, postnatal labour and that birth. And they're the lead professional for all women and newborn infants, and it is about optimizing that care for that birth, for that woman and obviously that child that is then born. Next slide. Entry requirements is 120 UCAS points. In the same way, you've got your people undertaking BTEC program, so it's about the UCAS points that BTEC would carry. 5 GCSEs, once again, English, maths and science at grade 4 above, and an interview for the same reasons. That interview is there that's different to other programs because we're looking at those other skills like care, compassion, leadership, preparation to make sure that that you are the right person to enter that profession. Okay. Okay, I've got just a question here from Audrey. If a university course says midwifery with leadership, what does that involve? I don't know. I've not heard of a specific university course that says midwifery, but I was going to say, Alex, I was just about to say, Alex will be able to answer that. So that's really good. Thank you. And I would assume the same thing about a module on leadership that is included. But to be fair, all of our nursing and midwifery courses will all have a module on leadership of care, because actually that's what the NMC requires you to do. Okay. So degree level course for midwifery is 3 years, 50% theory, 50% practice, acute hospital and community placements. And in the same way as the nursing, you're going to be, it's going to be a 45 weeks per year course. Okay. So that the course statistics are exactly the same as nursing courses. Once again, band 5 role on probation at 25.5, but the band 6 role has rapid progression after progression. Because you're an autonomous midwife, they enter the band 6 role quite quickly, and that obviously comes with a higher amount of pay of 32,000. Roles in advanced practice, management, leadership, research, education. So, for example, midwives can lead groups of other midwives. They can work autonomously. They can work even within their scope of practice. They can work as independent midwives. There is lots of scope. It isn't just a case of working as a midwife in a labour ward. The scope of practice, like the nursing, is so wide and varied and can take you anywhere. Next slide. I'm just conscious of the time, Max. Sorry. A little bit about financial support. There are student loans that cover tuition fees and the means tested maintenance element of that. So you are means tested. It doesn't mean to say you have to pay out your tuition fees in the same way as anyone else or pay this back immediately. It is repaid on once you earn over a certain amount. Okay. From September 2020, the government at last has announced some funding of at least £5,000 a year to help with living costs for nursing midwifery students. Some students may be eligible for more depending on their individual circumstances, and this training grant does not have to be repaid. So the only thing you're actually repaying is student loan. Now, there's no, I could get into a moral debate about this till the cows come home, but I'm not going to. But the most important thing is do not let that tuition fee and that means setting maintenance element put you off of becoming a nurse. Because if you had to do a degree in history, you would still have those tuition fees. The only thing is your course is a longer 45 weeks a year, so it comes with a bit of challenges. But most of our student nurses, they do some work in their own time to obviously supplement their financial support, and they quite often do healthcare work as part of that. So that sort of thing. So we said here, do we have to apply? Yes, all student loan, all student money, you do apply for it. Everybody has to apply for it. Yeah, okay. And there are every university will take you through that guidance.
I was just going to jump in quickly. Well, two things actually. The point there, do you have to apply for it, is automatically given. Students, you'll need to learn pretty quickly. If there's money out there that you can have access to, you've got to go and find it. It's not automatically always given to you. So make sure you do the research. But on the point that Tash made a second ago, students that are on this session and have seen me on other sessions and come to pathway sessions know exactly what I say. We are not here to tell you that one is better than the other, because we cannot do that. The point of being here is to do your research. And I always say, you do your research and find the solution that is better for you. And that's why when you hear about apprenticeships or university, you're getting a degree. You're just getting it in a different way. Which one applies to you? Which one are you going to be better at? But then obviously the financial considerations come in, but you have to decide with your family what is better for you and what you can manage. Don't let that say that one is better than the other, because they are both extremely viable options. It's about doing your research and learning about these things. And then to that point, always go and search for the money. You come to these sessions, ask what is happening, can you get grants, what are the loans, all of this. Nothing is always automatically given to you. There's probably more out there available than you know. And then Tash, I don't know if you saw, there was a question beforehand from Chloe about wanting to be a
dual sorry, missed it. Yeah, dual nursing midwife. If I do a nautical, is there a way to then take a midwifery course? Yes, there are some areas in the country of doing these top-up midwifery courses. There are shortened courses that are available once you've actually become a nurse. So you can definitely do that pathway. And Alex, I know that there's, I think it might be City that do it in London, but there are a couple of universities. Alex might know a little bit more, as she's a midwife, of how you can then go on to be a midwife afterwards. I know a couple of my colleagues have gone on to do it, have gone on to do midwifery after their nursing. They've worked, say, for a couple of years and then gone off to do midwife because that's what she chose to do. So it's really good. So the world is your oyster in terms of those pathways of how to undertake nursing and midwifery. Okay, so one of the things, next slide here, things to consider. You've got to look at you. This is about where you want to live, what you want to do, where you want to work, and what you want to work with. What role suits your values? Your values are really important to you. About the thing, I always think, the thing that makes me the person I am. What motivates you? And you've got to consider that in terms of nursing, midwifery, the type of nursing. And it's really hard. Some of you may be year 9 on today, and it's really hard to think about your future in year 9. And what's quite nice, and we're going to talk about that, is the pathway you choose now is not the pathway you have to stick with for the rest of your life. Okay, it's just we're producing this information to you to maybe help you shape a path that you might want to take. Okay, and making sort of explore your minds, but it's got to be about you and what is manageable for you. So next slide. So if you're interested in these are just some websites. Are you going to circulate the slides, or do they come up on your, yeah? So there's a number of different websites. I'm sure if those of you have been doing your research have come up to that. And yeah, and I think that's the last slide actually, Max. So thank you. And I'm just whistling through because Amy's next. Is there any other questions? I think the most important message for me is we've presented that university pathway, but I think it's about what is important to you.
And also don't forget that we are having a Q&A later this afternoon as well, and you can put questions in through the chat box as we go, because you're going to see the next section, and then we've got Q&A later today. And also let's be bold, Tash is back a little bit later for her other section, so if you've got questions, don't forget you can ask her later too. We're fairly flexible in the day. Okay, fantastic, brilliant, thank you very much for that. Now you get to meet Amy. So Amy, welcome to the session. We're going to see this on the other side.
Yeah, so I'm Amy. I'm a work-based learning and apprenticeships advisor for the Trust. So work in the work-based learning and apprenticeships team. So work closely with Tash through the apprenticeship route. Previously, I've worked for universities as a skills coach for nurses, but also at the National Apprenticeship Service as well. So lots of experience in apprenticeships in general. But I'll be talking about the nursing pathways that we've got, and also sort of touch on other sort of routes as well. Next slide. So I do have a video, but I don't know if it's best to maybe send it out with everyone, if we can go through it, and if we've got time at the end, maybe play it. But it's just an introduction to the Trust in general. It talks a little bit about merging. So we've merged from 3 to 1 recently. So we're one of the largest trusts currently in the country. We serve a population of 1.2 million people. So just a little introduction as well, our ambition to deliver excellent and local specialist services and improve the health and well-being of patients across the region. Next slide. So this slide just shows the 3 main sites we operate in, so Basildon, Broomfield and Southend, but we also provide community service in hospitals in Orsett and Braintree as well. Okay, so for our trust values, it's quite important in any role that you're applying for within NHS to represent these values throughout your work. So if you're applying directly to the NHS for a job or for an apprenticeship, or if you're applying to the university courses, you'll be asked about these during the interview and how you can demonstrate these within the role, how you have applied these previously, like examples of how you maybe show these values. And then these are the 6 values across all NHS trusts across the country. So working together for the patient, respect and dignity, community of the quality of care, compassion, improving lives, and that everyone counts. So whatever role you're in, whether it's nursing or other clinical roles or cleaning, admin, catering staff, all staff members represent the NHS values. So this slide represents the 3 additional values at Mid and South Essex Trust. So excellent, compassion, respectful. And again, all staff show these values, demonstrate these values, and they are recognised 2 through what we call value awards. So these are monthly awards that show appreciation for the staff representing these values, and show them through how they've sort of behaved in their role in work supporting patients. So yeah, these are recognised as well. So it's important to demonstrate these. Okay, so careers in the NHS, there's over 350 different careers available. So some of them you have heard of, so nursing, midwifery, doctors, but also some that you may not have heard of before. There's lots of different apprenticeship routes and ways in. Some of them don't require any degree, or some of them aren't directly patient-facing or clinically hands-on. But here are some other examples. So, of course, the nursing midwifery that we're going to talk a little bit more about today. There's medical and dental, so doctors, surgeons, consultants, as well as allied health professionals. These include speech and language, also as well as physiotherapy. We also have dietitians. They all are included in that category. So health science as well, and then other areas. So currently within our trust we have 401 apprentices. They're on programs, various different programs, so IT services, also nursing, health and social care, but starting from level 2, which hopefully you can see it's equivalent to 5 GCSEs, A star to C, and then up until higher and degree apprenticeship, where level 7 is equivalent to a master's degree. So from GCSE to master's level apprenticeships in various different roles. We work closely with lots of different training providers, colleges, universities in the area. They deliver the theory side of apprenticeships through online learning or face-to-face sessions. But one thing with apprenticeships that you might hear a lot is off-the-job learning. So this is where this includes learning with apprenticeship training providers, so universities, going to university or online learning. But it also includes any learning that you do on the job, so developing new knowledge, skills, behaviours for the role. So mentor, like following a mentor, and maybe watching medication rounds and see how they're being completed, and learning from colleagues too will be included in that. Okay, so the nursing career pathway is one of the career pathways that we offer at Mid and South Essex. So there's no direct route to apply specifically for the apprenticeship directly at the moment. So what we
Come back to us, Amy.
Hello, am I back? I don't know if that was just me.
No, that was just a small glitch, but you are back. We can hear you and see you again.
I think we're having problems because mine keeps going as well. So there's obviously a problem with the MSE at the moment or something.
Okay.
So I was saying, so there's no direct entry route, so you can't specifically apply for the level 2 healthcare social support worker apprenticeship. What we do is because you need a certain amount of experience in healthcare beforehand, we recommend applying for a healthcare support worker role in an area that you're interested in, and then we're able to support you with the support from the managers and department of your area to commence the nursing career pathway is what we call it. So although it looks like it's starting from one end to the other, you are able to join certain bits, and I'll explain sort of entry requirements to each section. But this is an example of the nursing career pathway. So starting from a healthcare support worker, and then working your way up through the bands up until band 5 registered nurse. And also, as Tash mentioned previously, beyond this, there's also level 7 qualifications for leadership, level 7 advanced clinical practitioner placement. So again, not the end of career development, but just an example of what we can do. So this slide is a little bit about the level 2 and the level 3 healthcare support worker apprenticeship. which is where most people start if they haven't got that much experience beforehand, or if they've not got a level 2 or 3 qualifications. So the level 2 is a 12-month program, and the level 3 is a senior healthcare support worker, and that's 18 months. So for both, you need 6 months experience in healthcare. As an experienced support worker, you carry out a range of clinical and non-clinical healthcare tasks, and this is under the direct supervision of the registered healthcare practitioners. So it's following certain standards and policies and protocols. So this is for anyone who wants to remain as a healthcare support worker but develop their knowledge, skills, behaviours in that area, or for anyone who wants to sort of develop themselves beyond that role as well. So this is the level 5 trainee nursing associate apprenticeship, also known as the TNA. So individuals will need to have at least 12 months experience in a healthcare role. So this can include different healthcare organisations that Tash had mentioned on previous slides. So working in a care home as well would be a brilliant experience in healthcare. But this one also requires having the level 3 qualification beforehand, and this is in any subject. So if anyone hasn't got level 3, we recommend they start on the healthcare support worker apprenticeship programs. But if you do come to us with a level 3 qualification already and some previous experience, then you would most likely start at this entry point, so starting at the level 5. We do require level 2 English and Maths. We do support you to get this if you haven't got it already. That's at no cost to you or your ward area, so we'll be able to fund that through the trust to make sure that you've got that level of qualification in English and Maths. So that's the same for most apprenticeship programs before you start, but you must have it at the end of all apprenticeship programs to have the English and Maths. So as Tash mentioned previously as well, so the nursing associate role does bridge the gap between healthcare assistants and registered nurses. So as the registered nurse role has advanced, it's just to make sure that there's that gap in the middle for care and support. And this is also, you will also be registered as a nursing associate on the NMC register, and you will be able to progress through into graduate nursing level qualifications. So for example, the top-up degree, which I'm going to talk about next. So next slide. Okay, so level 6 is a 2-year top-up degree program. So once you've successfully completed the level 5, you can either stay within the band 4 role of a nursing associate and complete that role to support patients and colleagues, or you can apply for the top-up degree, which is a 2-year program. So you are required to have that level 5 qualification before you start, and level 2 English and Maths. And then the next few points, just explain a little bit about the nursing role, responsibilities and accountability for your work, and upholding the NMC code and requirements for registration. So this is our midwifery career pathway, which is currently in development. We do work with lots of different ward areas and departments across the trust to develop all sorts of apprenticeship opportunities. So the level 6 midwifery degree apprenticeship does exist, and we do support apprentices on that route. We're just developing a pathway where we're starting maybe from a level 2, level 3 to work and support people up through the apprenticeship route too. So this is upcoming, but currently this is offered to support workers within the midwifery team who want to develop and become a midwife. So apprenticeships, all apprenticeships, as I mentioned before, functional skills. So functional skills, if you see that, is equivalent to level 2 English and level 2 Maths. So GCSE A star to C or 4 to 9. Yes. If you haven't got that though, we can support you with local colleges to get that, and we'll fund that for you to ensure that you've got that. And that normally there's a few different routes to it. So if you are quite if you need extra support, we've got extra support routes. If you're quite skilled and you've got the ability, we can do a quick assessment and then put you through some exams. So there's lots of different options to get your English and Maths if that's something you've not got currently. So difference between the university route and the apprenticeship route is that the apprenticeship funding is funded through the organisation's apprenticeship levy. So you won't have to get the student loan out for it because it's covered through the trust. So that's for all of the routes. If you do one apprenticeship, two apprenticeship, the funding is always covered through the organisation. The only thing is that you'd have to stop one before. You can't do two at the same time. You'd have to just be doing one funded programme at a time. But that does mean it's quite a popular route, so that's something to consider as well. So no university fee, but you do attend university and college. You do get the degree certificate, you get a graduation. So that's another benefit, and then you can earn while you learn. So starting from the band 2 roles up until band 4, band 5, and so on as you go through this route. So I'll talk a little bit now about the application process and including a few tips as well. So currently vacancies are advertised on NHS Jobs, but you can also find them through our trust website. So these include a job pack, which include the job specification, person specification, job description, and any other relevant information. And there's sort of a 5-step process. So completing your application form, and then the hiring team will select certain people for interview, so shortlist. Stage 3 is the interview process. Stage 4 is the pre-employment check, so maybe checking qualifications, making sure that we've got documentation needed from you, and then offer of employment if you're successful. So the next slide just has some application tips. So when applying for an apprenticeship route or applying for the healthcare assistant route, these are some tips that we give. So checking the closing date, but also trying to apply early, because often if there's a lot of applications, the closing date might maybe move forward. So it's just something to consider if you see something and you're interested, to try and do it as soon as you can. When you're completing the application, just making sure that you've got all the information with you to complete the application. So national insurance numbers, certificate details if needed, previous employment details, references too. Making sure that you read the application pack. Do you meet the essential and desirable criteria? If you do, just like highlighting how and giving examples. So you can give examples if you've not had a previous job, like life examples, life skills. So for example, for a teamwork, if you may work, if you play for a sports team, how can you include the certain skills in that team? What do you do? What skills do you use? Communication skills, examples like that, just to show how you meet the criteria. So don't rush your application. Remember to proofread, check for spelling and grammar, and then if you want to apply for more than one, which you're able to do quite often on the NHS Jobs website, or save details that you've had before, it's just adapting the personal statement, making sure that it's relevant for the role, and giving best examples for that. Another one as well would be to include the NHS values, how you can relate to that, using examples too for that. So we offer work experience. So you can work in various different departments across the hospital, clinical, non-clinical areas. Some roles you have to have experience within a hospital, so it's a good way of doing that to get a work experience in. So for non-clinical areas, so like admin positions, there's no age restriction, so you can apply for that at any time. for clinical work experience, you need to be 17 at least, and for midwifery 18 or above. I've got email address there too for that. Another way of getting experience would be volunteering. So a range of different volunteering activities, and then sort of talking a little bit about the benefits of volunteering, and that there is a interview and reference and DBS check as well for all volunteers. So there's a volunteer contact details there. This is, I can also answer any questions that we've got about apprenticeships, but just if you've got any after today, please get in contact with us. I think that may be my final one, because I try to get as quickly as possible. If anyone's got any questions, please let me know.
There is a question straight away for you. And that's good information as well, because we need to look at those different routes in. And remember what I said at the beginning of this day, student success means that my role is to now help you understand more of this and unpack this information and make the right choices. So that's why you use us after today. And Chloe's asked, in order to become a registered nurse through an apprenticeship, do you need to first become a nursing associate?
So most of the time you do have to have that level. Through the apprenticeship route, you do need to have that level 5 nursing associate, or there's also an assistant practitioner one, depending on which route you follow. We can consider other types of healthcare experience at a level 5, but for the nursing degree, for the top-up degree, you need to have that level 5 learning. We are looking at the possibility of doing the full nurse degree program, which is a 4-year program, and then that will be sort of the same entry route, so level 3 qualifications similar to university, but at the moment it's a top-up course that's been offered across most of the NHS trusts.
Fantastic, brilliant. Okay, that's a lot of good information, and remember we've got Q&A this afternoon as well, so thank you both to Tash and to Amy to come and explain both those different routes. Remember what I said, there is no, you cannot say one is better than the other. It is about making those individual choices and doing the research to find out which one is best for you. Okay. And Sophie's just asked a quick question. She's heard that universities aren't going to take people who haven't got their maths and English GCSE firsthand, and my year was affected by COVID a lot. I don't know the answer to that question. I don't know if anybody here does know the answer to that question, but if that does happen, then that's going to be a struggle for a lot of people, and the apprenticeship route will become a lot more attractive.
You've answered it correctly, Max. There are some universities that won't be able to get to work, but some universities won't take people without their maths and English if they're going into that direct entry route. And then some universities are taking them without it, and it's part of the course. So it just depends on the universities. And it's only some universities, but yeah. But you know, I know from where I used to work that individuals did need to have their English and maths before they were able to enter the programme.
So there you go. So that's again another point of doing your research so that you can get the right information. And so that means it will close some doors for some people, but then remember that the apprenticeships and degree apprenticeships are there as well, and there's a lot more support given. I will say in terms of getting those C grades at English and maths if you need them. Okay, thank you very much for that. Really, really appreciate it. Thank you for your time. I'm sure we will see you later for the Q&A, but now we are going to move on to speed meeting people. With the speed meets, we've got 4 people that have come in to speak. We're going to have Alex, Ellie, Rebecca and John, and I'm going to spotlight them all in a second. And what I will say to the 4 people that are speaking, don't panic if your line cuts out and you have to come back in. I'll keep an eye out for you. And I know that as is real life, and we are working, remember that the volunteers that come here are doing a real job, and this is, they're taking time out of their day to be able to do this. And in reflection on that, Alex has a meeting to get to, which was not planned. However, we're going to get Alex to do a quick introduction of herself, because we are meeting Alex later this afternoon as well. She's going to be going through one of the activities with us, so we get to ask her more questions then. But Alex, why don't you go first? Give us an introduction about you and what you do.
Thanks, Max. Hi, everyone. I hope you can hear me. My name's Alex Black, and I'm a midwife. I was a direct entry. I didn't know what I wanted to do when I left school. My parents said I either needed to get a job or go to university, and I chose midwifery as my Career choice, not gonna lie, I didn't enjoy uni just for the first 6 months, but my parents are like, well, it's either this or get a job, so I thought I'd see the first year out, and I've not looked back since. I've done it. I qualified 10 years ago now, so I've been my training started in 2009. I'm looking forward to having a bit more of a chat with you later, and I'm really sorry, I'm going to dash off now because otherwise I'm going to get in trouble by my line manager, but I'm really excited to speak to you all later. And midwifery is very diverse. It's very different to nursing, but it's, you know, there's lots of things in midwifery. It's not just about cuddling babies. I mean, I can't remember the last time I picked up a baby and had a cuddle with them when I was at work, but I'm really looking forward to speaking to you later, and I hope that you have a lovely rest of your morning. So I'll see you at 1 o'clock.
Perfect. Thank you very much for that, Alex. Really, really appreciate it. What I'm going to do now as well for everybody is I'm actually going to stop sharing my screen so that and I'm going to spotlight the four speakers, pardon me. Oh no, it is three. So we'll have the 3 speakers on screen and you should be able to see them properly. But I can see 2 of them, and then John is going to be on in a sec. He is on, but we will see him in a second. But I'm going to come to Ellie. Good morning, Ellie. How are you?
Sorry, technophobe. I think I'm unmuted now, am I? You can hear me?
You are definitely unmuted. Welcome.
Perfect. Hello, I'm Ellie Wilkinson. I am maternity care assistant at Brimfield Hospital. Some trusts call us maternity support workers, but it's the same job. And the clue is in the title. We support everybody working maternity to help everything run smoothly. I have been in my job for just over 2 years now. I came as kind of a second career. So when I left school, I went to university and did a degree in science and worked as a scientist in labs for many years. And then I went to have my children, had my family, and stopped working for a little while. And then I had always, in the back of my mind, had the thought about training to become a midwife. Would that be something that I'd like? And I thought getting a job as a maternity care assistant would be a really good way of finding out if that was a path I wanted to follow. And so I've started, and I've kind of come to the conclusion now that actually being a maternity care assistant is the career that I want rather than to train to be a midwife. I think there's a really important place in maternity for really good maternity care assistants. So that's where I am now. So I've worked, there's many different wards in the maternity. There's labour ward, postnatal ward. There's the antenatal clinic before the mums have their babies when they're pregnant and they come in to see the doctors and the midwives. And I've worked across all of those wards. They all have very different roles for maternity care assistants. You do some very varied work. So I think, as has been spoken about in the previous talk, kind of when you first come in as a maternity care assistant, you'll start as a band 2, and that role is very much more of a kind of housekeeping role. There's a lot of cleaning, there's a lot of stocking of the wards, fetching things for people, also supporting the mums. And then as you get more training and more experience, you'll move into kind of more band 3 work, which is more clinical stuff, so taking bloods, performing observations on babies and mums, helping with feeding support, so that's bottle feeding and breastfeeding support. But basically our job is to support the midwives. I think the biggest myth for a maternity care assistant, probably highlighted by the Emma Willis programme, is that we're always there for the deliveries and we get to catch the babies, which we don't at all. Certainly at Brimfield, we're not in the room when the babies are born. You very rarely see a delivery, and we don't really go into theatres either. That's something that I think some trusts do have maternity care assistants in theatres, but we don't do that. But we are a massive support to the midwives after birth, and supporting the mums and the families after they've had their babies, during the night on postnatal ward. If the mums are really tired or feeling really unwell and they just need some support, we can be there to help. So we do get a bit of cuddling babies. It's not all cuddling babies, but we do get a little bit of that, which is lovely. At the moment, I work on antenatal clinic, which obviously is no babies because that's before they're born, but we help run a clinic. So we make sure they run smoothly. We take bloods, we check blood pressures, we dip urine, and generally get involved in that side of things. But yeah, as maternity care assistants, we kind of have different people coming into the job for different reasons. So we have people more like me who've had their families and want to come and have a job after they've had their children. We have young people coming in as well who are maybe interested in following the becoming a midwife, and I think it's a brilliant way to get an overview of how maternity works before you go into your midwifery training. I know they've just started at Brimfield, all of the year 1 midwives who come on their first placement, they spend their first day with the MCAs to get an overview of how the ward works, and that they've said that that's a really good idea.
I love the fact that we're going to unpack in a minute, because we're going to come back to you about that bit about the choice that you have made, because that's quite interesting. But you do have one question from Sophie, because we are going to have questions as we go along. As a midwife, do you have to take blood and give injections? Because she has a fear of needles herself, but she will try and overcome that fear. And I'm sure she's not going to be the first person who's going into this kind of role, potentially with that kind of fear. How do you get over it?
Absolutely. As a midwife, yeah, you do have to give injections and take bloods. I would say it's very different doing it to somebody else than having it done to yourself. So I know lots of people who feel faint and have fainted when they have blood taken themselves, but if they're taking it from somebody else, they find that a lot easier. And you'll start off gradually. When in your training, you'd start off taking blood from a plastic arm, so you're not actually doing it on a person to start with, and you'll gradually kind of ease your way into it.
So again, of course, you're all supported in this as well. You're not going to be the first person with a fear of it, Sophie, and I think you just get used to it. Interestingly, my wife went to be a blood donor carer, so she was taking blood from people who went to donate it. She's not fussed by any of this stuff, but there were people on the first day of her training course who did faint, but then they got used to it. So, okay, brilliant. Ellie, nice to meet you. Thank you for that. I'm going to move on to Rebecca, but we're going to come back because everybody's going to have lots of different questions thrown at them. So Rebecca, let's meet you. Welcome to the session. Tell us about you.
Thank you. So my name's Rebecca Ellis, and I am a learning disability nurse. So obviously learning disability nurses are the smallest branch of nursing, and a lot of people don't know about us still, despite us being around for about 100 years or so, I think. So my route into nursing wasn't a direct one exactly. So straight after my GCSEs, I got a summer job as helping out in a patisserie, and then I decided I'm not going to go do my A-levels. I'm going to stay at the patisserie. I'm going to train to be a patisserie chef, and that's what I did. And then a couple of years later, I decided this isn't really exactly what I want to do. I would like to work with people with learning disabilities, and a friend of mine had just started children's nursing and said to me, "Oh, you know there's learning disability nursing," which I didn't. I went to the open day, and just like with the previous question, my only question that I asked was, do I have to give injections? And they said no. Now, I can tell you that that was incorrect. I did have to give injections, which was quite a surprise whenever it came to my second or third year, but I ended up putting myself forward for every single injection that needed to be done to get over my fear, and it did work. So yeah, there is always hope. So learning disability nurses, there's only about 3,200 learning disability nurses within the NHS. A lot of universities have reduced the number of courses that are being done in recent years. I started my training in 2009 and was the last cohort that went through Anglia Ruskin University in Chelmsford before the course was stopped. I was also lucky enough that they were still doing diploma nursing at the time, obviously because I didn't have any A-levels. There is a variety of environments that learning disability nurses can work in. When I first qualified, I spent time working in inpatient settings. So there are specialist mental health hospitals for people with learning disabilities. There's not loads of them. There's very few in the NHS, but there are others in the private sector. Obviously, there was the whole Winterbourne scandal was about 12 years ago now, perhaps. And there's been a big push following that on transforming care and moving people with learning disabilities out of long stay hospitals, where people were sort of being placed and then sort of getting stuck. So there is inpatient settings that people can work in, and it's about supporting people to get better, and then they're moving out into the community where they can live more fulfilling lives, have more independence and the better quality of life, because hospital obviously is only to get better, so people shouldn't be stuck in there long term. There is also, so at the moment I work in the community learning disability team for Mid West Essex, So within the team, there are different professions. There's psychiatrists, psychologists, OT, speech and language, physio, dietetics. There's loads of different professionals. But in nursing, we have community nurses who are mainly focused on supporting people's physical health. And then the enhanced support team, which is a team that I work for. So in the enhanced support team, we are more about supporting people who may be in mental health crisis. So supporting people to get better, to stay in the community safely. We also support people moving out of the inpatient hospitals. A lot of what we do is admission avoidance, but we have to put that support in place for people. And also when people are presenting with behaviour that challenges, it's about seeing what's going on, why is the person acting in that way, and then trying to put things in place so the person can reach the same outcome without having to present with behaviour. It's busy work, but obviously it's very fulfilling whenever you can help someone to safely remain in their home instead of having an admission into hospital where they might end up for a long time. A lot of what LD nurses do as well is promoting, and so we try to minimise the health inequalities that people face. So people with a learning disability are at a greater disadvantage than people without a learning disability. They, on average, do die younger than people without a learning disability. There is currently a review called LEADER report. It looks into the premature deaths of people with learning disability. And on average, people with a learning disability do die 22 years younger than people in the general population. And 49% of the deaths are unavoidable compared to 22% of the general population. So we do a lot of working with GP practices, other health settings to try to minimise barriers to people being able to access the services, so we can reduce the health inequalities, put reasonable adjustments in place to try to help people to live their full life. There is also other settings that people can work in. We do have a lot of hospitals now have LD liaison nurses that work within the general hospital, and they can support people that go into hospital with a learning disability. They can support the staff on the wards to be able to make sure the person gets the care that they need and reduce any barriers. And obviously the community nursing teams can help with that as well. We also run forensic teams that assist to support people that have come to the attention of the criminal justice system. So some people will need extra support, so they've got a risk of offending or they have offended before. There's also some nurses that work in the prison system. It's not unusual for people to end up in prison. Obviously, the definition of learning disability is a diagnosis of an IQ of 70 or less. So there are some people that sort of just are on that cusp, that they're not always diagnosed. And there is still a lot of misunderstanding about what learning disability is. Like, we do receive a lot of referrals from GP practices for people that have dyslexia or autism, and then by themselves they're not a learning disability, they are other conditions. There's also obviously working in children's services, might have children inpatient services or community children's teams. Also know of nurses that work in special needs schools to support there. You also get LD nurses working in elderly care homes. I know a lot of the sort of dementia wards can be quite eager for learning disability nurses to work there, because I think they see that their skills can overlap a lot between the two of them. Yeah, I don't really know if there's anything else for me to say.
Cool. No, that's good. That's a lot of information. It's good as well, because what we're seeing here, again, remember, we're looking at those different roles, and we said about this morning in the word cloud, what are the different types of nursing? And this one didn't actually come up too much, did it? and it's quite an important one. So you're getting information there already. Start thinking about questions that we're going to have, both for Ellie and Rebecca. And what we're going to do now is John. We are going to meet John. So John, I mean, I've got the brief here, and it says here you are an EPUT or EPUT. I have no idea what that is, but you're going to enlighten us. So welcome to the session.
Thank you. Yeah, I actually have 2 jobs, so I'll go through them both. But yeah, my name's John. I am a registered nurse and adult nurse. So we basically deal with anyone from the ages of 16 up, and predominantly we deal with their physical health conditions. So I qualified in 2019, and I started working in A&E full time. And then back in May last year, I began working in EPUT, which is Essex Partnership University Trust. And they're predominantly a mental health trust, but I work in education there, so I still do the 2 jobs together. My route into nursing was a bit odd, I suppose. So I actually went to college and studied music, music technology. I wanted to be a sound engineer. I wanted to go into events management. And then, funny enough, me and my mate were talking the other day, and I had in about the space of a year about 6 different jobs, until finally I got into a healthcare assistant role. And then from there, I went and done the traditional 3-year degree at university. In 2016, I started that. I qualified in 2019, and then I started working in education back in May. The 2 jobs sort of show the diversity and the variety you can have as a nurse, because I've gone from being in a clinical to a non-clinical role, but maintaining both. So for me, being qualified only 1.5 years and going into education, I still wanted to be clinical. And I love working in A&E. It's very varied, the sort of people you get in. It's stressful and it can be frustrating at the same time. But for me, I like the skills that I've learned. There's a lot of different people you meet. You support some really good staff, and you get really good support there from the people you work with. I've been in weird situations that, puts weird looks on people's faces when I tell them about it, especially my mates. I'm the only clinical person out of my whole bunch of mates, really. And then to move into education, I like teaching anyway. So at the moment, we're working on international nurses who are coming over, and we're supporting them and getting them trained up to be qualified in the UK. The teaching them is really interesting as well. Nursing itself is very varied in the routes you can go. We've got obviously the inpatient settings, we've got wards, then you've got community, obviously education. They also have adult nurses in prison services, in private clinics, GP services, and you can progress quite high up. So as nurses, we don't sort of diagnose and things like that, but you can go on to do courses that let you. So in A&E, we have emergency nurse practitioners. They assess, they diagnose, they prescribe. And in GP practices, they do the same thing as well. And I know that, because it's something I was interested in, they're looking at a sort of paramedic nurse role as well. So they can go out and work in the ambulances as a qualified nurse, and there'll be like a transition to that. I know they were doing it, I think it's in Bedfordshire they were doing it, and they're looking at doing it around Essex. But for me, nursing wasn't anything I thought from the get-go I was going to do, and I never thought I was going to do anything like this. And it was only I sort of fell into it, and I'm glad I have, because for me, it's a job that you can keep for life. There's so many different career pathways and progression for it. I never thought I'd go into education either, so even to take on this role was amazing for me. And that's about it, really. I don't know if there's anything more you want me to say.
Ooh, there's going to be plenty more that we're going to get you to say, but it's interesting again to see that the different type of role, and then we'll get into more questions about your day-to-day and what that looks like in A&E. But for students, what we want to show you here is look at the three different roles and the 3 different settings that we've got in the varied settings. I'm going to ask a couple of questions now. Ellie, I'm going to come back to you because you said something interesting, but I want to cover off a couple of things. Did you always know that this was the route you wanted to go into? I'm going to guess no, but that might be the wrong answer.
No, absolutely.
When did you, wait a second, when did you kind of know? But then also, did you go in, when you did finally decide to go into this route, did you go in with the intention to go on to be a midwife?
No, I definitely didn't know that this was the role I wanted to go in. My mum was a nurse, and she always said to me, do anything but don't be a nurse. So that kind of put me off the clinical side of things. As I say, science was really my thing. That was what I was always kind of good at school, and I went into science, working in a lab. But then after I had my children, I kind of appreciated what the midwives had done for me. Then I had quite a tricky time. And that kind of made me want to go and give back to people and be that person that could support people. I had a couple of friends that worked as maternity care assistants. So I kind of went in with my eyes open, knowing that it wasn't cuddling babies. It's a lot of cleaning. It's a lot of hard work. Shift work is not for everybody. It is hard work. You probably will work Christmas Day on numerous occasions. And so, yeah, I did go in thinking maybe I'd like to qualify as a midwife. At the moment at Broomfield Hospital, there is no opportunity to go through the apprenticeship. I believe that is, they're talking about bringing that in. At the moment, that doesn't happen. So if you want to go into midwifery in my area, you have to go to university, which is kind of 3 years full-time study. I have a family to support, so working is kind of what I need to do. But now I am an MCA and I've been doing it for a couple of years. I actually really love it. And I think for me, at my part of my life, this is the right thing for me, because the midwives are so busy, they are so run off their feet, and we get the opportunity to have that time to spend with the families and the women and just be that support for them at whatever stage of their pregnancy journey they're at. We can be there to support them, and that is what I love.
That's the interesting thing, because I always talk to students about, remember what I always say to students about making the choice that is right for you. And even if you make a choice now, it doesn't mean that it's going to be the right choice in 2-3 years time. So things will change, and be open to that. That when you find something and then it changes your opinion, like in Ellie's case, the perception of fact, for my life and for where I am right now, this is what I love and this gets me out of bed and I enjoy it and it fulfills me. Why change it? Why do I need to go on and do something different? So always think about that. Those options are there, but it's good to see. Okay, and also the point about the fact that yeah, you are in a situation where you've got to think about supporting your family, but you enjoy what you do, right? It's not like you made a compromise. You actually do enjoy what you do.
Oh, absolutely. I absolutely love it. I do. I mean, it's hard. Any job is hard and is mundane and has days where you just don't want to be there always. I don't think there's any job that anyone has, they don't feel like that. But yeah, I do love my job. I'm really passionate about it. And I think it's really exciting times as well for maternity care assistants, support workers. They're bringing in nationwide, I think, a framework so that we all follow the same path, and there is going to be opportunities to progress from band 2 to band 3, sometimes band 4, as you add to your clinical skills. So it's a really exciting time to be a maternity support worker.
Brilliant, fantastic, thanks Ellie. Okay, Rebecca, back to you. So something you said that interested me, you said, and if I got this wrong, correct me, you knew you wanted to get into learning disability. Is that right?
Yes.
How did that come about? Why did you know that? I mean, obviously I never had that thought, but other students on this call may have had that thought. But what made you want to get into that? What was it that sparked that?
It was quite a personal thing for me. So whenever I was a teenager, I had a younger sister born who has Down syndrome. Okay. And I'd never even met a person with a learning disability before, to be perfectly honest. Hadn't even crossed my mind. And I think that is the case for most people. If you don't know anyone with a learning disability, you don't consider people with a learning disability, if that makes sense. And I think after she was born, I started to realise just how unfair the world could be towards somebody with a learning disability, and the extra support and understanding that is needed to enable all people with a learning disability to have a good quality of life. And that's what really made it for me. It was that I wanted to, as cliche as it is, I wanted to make the world a better place for her. And obviously that's what me and all my colleagues are trying to do. And I see it every day that people really are passionate about what they do. And a lot of what we do is about educating. Because like I said, people just don't know how to support people with a learning disability. There's assumptions that are made about them, about their care, their understanding. But with the right support, a lot of people can live quite an independent life, and it's about putting the minimum restrictions in place on a person so that they can achieve that, and the support so they can achieve that, whether it be living in their own home and having carers going in, or they live in a residential home, and enabling people to have that community presence. Some people can be supported to find jobs, get paid employment, I know within our trust, we have actually hired health access champions. So they're members of the team, they have paid employment. These are people with learning disability that come in and they assist in putting together plans about how we can access people with a learning disability, to encourage them to take on the health screening and things like that that is needed, because a lot of people with learning disability don't actually access things like smear tests, mammograms, and even dentists. It can be quite difficult, and there are specialist services available, like there's community dentist centres specifically for people with who suffer from a lot of agitation or challenging behaviour, but unfortunately the services are very limited at the moment. I won't pretend that they're not, and it can be quite difficult to access them. And it can be the same with social care as well, but that's what we do. We spend a lot of time trying to liaise with other professionals to sort of reach the desired outcome, but it's always about putting the person first. What do they want? What's their choices? Everything is centered around them, and obviously it does include liaising with families as well. There are difficulties sometimes, like people may not always be quite as receptive as we might hope, but that doesn't mean that you don't try.
Absolutely, of course. Okay, brilliant. Okay, so it's good to see again the motivations behind why people go into the roles they want to. And what is also the message I always say to students, and I want you to think about, is that there is time to make decisions. There is time to figure out what you want to do. Don't put too much pressure on yourself that you need to have the answer today or this year or now. And even if you make a decision, it will change. But also just think about what it is you enjoy, what experiences you've had, or what you do. And a lot of students that I've worked with in the past who have wanted to go into different types of nursing often have that story like Rebecca about a family member who's been needing care or support, and that's where they've got that compassion and that passion to want to get into that role. So use that as well and think about it, because that is an absolutely valid thing. John, though, on the other hand, I want to know more about what's it like in A&E. Now, I'm not going to lie. I'm a fan of all the TV shows like 24 Hours in A&E. Like I said, I live like 2 minutes away from St. George's Hospital, so I love seeing what goes on all the time. Been a few times. But yeah, so how is that different to the settings that like Ellie and Rebecca in then? And is it as stressful as it looks?
Yeah, it is as stressful as it looks, and if not even more so. When you see the real shows like 24 Hours in A&E and things like that, what they're showing you is what is called resus. So in A&E you have different areas, and resus is sort of like the critical area where the worst people, the people that are in the worst state or the most ill go. So you get to see that, you get to see sort of the severe cases, but what they don't show you is the other side of when you've got, you know, no capacity, you don't have places for ambulances to offload, there's no space in the hospital. And this isn't just my hospital, this is NHS wide, and this isn't me trying to put you off it, but the real situation in the NHS is the fact that, and as everyone else has said, it is underfunded to an extent. And they are trying to do stuff about it, but I mean, A&E is a very fast-paced area. We have people coming in with all sorts of things. So yeah, you have your critical patients, but we also have people that might have fractured a hip or might have quite a bad chest infection and need admitting and things like that. In that case, you've got a department that can be quite full, but it's almost a bit like a conveyor belt. When there's beds available in the hospital, they come A&E, they're settled, we sort of stabilise them, then we move them on to be admission for continuous care. When you see shows like Grey's Anatomy and all the rest of them, it's nothing like that. Please don't believe that. But when you see the real shows, and there's actually one that's not long been on, and it's something about emergency nurses. I think it's on ITV. So that gives you a bit more of an insight to the whole of A&E as well, I suppose. I've watched a couple of episodes and it does show a bit more into it. But A&E on a day-to-day is busy. But the people you meet are usually pretty nice. But then if you work a Friday or Saturday night, you know, you've got that side of it as well. But for the most part, you do get really nice patients. Some of them can be very patient for the fact that, you know, we are busy, we run off our feet. but I personally wouldn't want to, in a clinical point of view, I wouldn't want to work anywhere else. It's what I enjoy, sort of my bread and butter now that I've got used to it, and I love working there.
That's interesting because of everything that you say, but it's what you love, and that you wouldn't change it for anything. But did you, again, I know you did explain a little bit about your story, so you never really had any intention to end up in this role. Like when you were at school, you weren't thinking, that's where I'm going to be an A&E nurse. How did it then come about? What made you go towards it? And once you then started doing it, what has made you stay there? What is it that keeps you where you're doing what you're doing?
So to start off with, so I worked in the NHS. I got a job when I was 17 doing admin stuff. So I had an aunt that worked in the NHS in HR, and then they needed someone just with some filing. And it was the first job I'd ever had. And then I had a couple of different jobs in the NHS. And then when I was 20, I think it was, I then ended up working again in the education centre, but on the reception desk there. I then was speaking to someone one weekend when I was running a course who ended up being one of the head nursing for an area, but she was in plain clothes, didn't know. We were just chatting normally about something. And then one day she said to me, they were opening up this outpatient department in Brentwood, asked if I'd be interested in being a HCA. She said she thought I'd be quite good at it. And then I done that, got the job. Started working there, and I really enjoyed it. And then it wasn't until I started doing that job that I realised I quite like the clinical environment. I like the stuff you learn, I like the people you meet, I like that side of it, and the knowledge you gain as well. Like, I mean, not everyone's going to be like it, but like the anatomy of the body and sort of the conditions really fascinate me a little bit. I like what the body can do. It's mad what it can do. And then I just applied for uni because I thought I was young, I wanted to progress, and I thought, well, this might be something I could see myself doing. And it was funny, when I was at uni, every year I basically said to myself, if I fail this year, I'm just not going to worry about it. I thought, I'm going to try this out. If it don't work, it don't work. And then every year I managed to get through it, and I think I got a 2-1 in the end. So I was quite happy with that. And it's funny, I'm the only one in my family. I'm the only one with a degree in my family. I'm the only one in my family that does anything clinical. So I had no background of it whatsoever. And I just sort of fell into it. And it was nothing I ever thought when I was younger I'd go into, or even thought about. I didn't really know much about what a nurse was. And it wasn't until I sort of started in the NHS that helped. And for me, that period in between me finishing college and having a few jobs helped me realise what I wanted to do. Because originally when I started a job, I went to work in HR. I'm glad I didn't, because I think, I don't know, I think I'd be bored by now.
I can vouch for that because I have worked in HR for quite a long time. Yeah, and this is why I love the job that I do now, because I get to do sessions like this and meet students and people in different walks of life. So I love it. Okay, brilliant. Thank you for that. Now, Ellie, if we go back to you, let's get a sense of, I want to start to get a sense of settings and what we're talking about, because it's very easy to say, okay, we're talking to a maternity care assistant, a learning development nurse, a learning disability nurse, and an A&E nurse, and somebody who works in the education side as well. What does that actually mean for a student? What's the setting you work in, Ellie? Do you stay in a hospital? Do you work at GP surgery? Do you go out and do home visits? What is it like?
So I work in a hospital. So in a big hospital, we have kind of one level of the hospital is maternity. So all of the different wards are on that level. So it's a very busy place. So we do get a lot of women coming in to have babies. So that we have kind of the low risk area of labour ward where people come in and have their nice pool births and they're very simple, lovely, have a baby, go home. We have a high risk area of labour ward, so people with more complications. We have lots of emergencies happening. So we do have mums who lose a lot of blood after they've had their baby, some complications who end up going to theatre. So we have that side of things. We have a postnatal ward where mums go who need to stay in hospital for a little while after they've had their baby. We also have 2 standalone birthing units, which are separate, completely separate from the hospital. So we have maternity care assistants working there as well. They're much more low risk. So they are kind of much more home from home, less as kind of not as clinical as you can possibly make it. We also have mums who have home births. We don't really have maternity care assistants going out to them, but sometimes they might do if they're needed. We do also have maternity care assistants working in community, so they would be going out to visit the mums after they've had their babies to do the baby weighs and any kind of support that the mums might need up to kind of 10 days postpartum.
Cool, fantastic, thank you for that. Rebecca, what about yourself? Same question, give us a sense.
So obviously I'm in the enhanced support team. So our base is an office, but we mainly work in people's homes or in sort of residential homes, supported living places. There's a lot of liaising involved in our teams. So we might have to liaise with different professionals in quite a short space of time to arrange meetings or to get decisions made. So that can include GPs, psychiatry, psychology, OT, speech and language, physio, dietitians. There's all kinds of people that can be involved, including social care, and then obviously family members and things. So we generally work to reduce the escalation to acute settings. That is, so preventing admission to either inpatient or mental health hospitals. That's the general purpose of the enhanced support team. But obviously, if somebody does need to access that kind of treatment, then we can also support with an admission. Sometimes we also support on the inpatient wards, depending on the situations. We also can liaise with mainstream mental health services. So obviously we try to support everyone to access mainstream health services, and we might support people to attend appointments and things to enable that to go well. But whenever we look at more specialised learning disability services, it's whenever someone's learning disability is of such a severity that it prevents them from being able to access mainstream services. So every day is a bit different for me, to be honest. I might go to people's houses, I might go to residential homes, I do spend a lot of time in meetings, to be fair, especially now. Teams is a thing, it's easy to get people on it. But there is a lot of different settings that people could choose to work in. Obviously, where I work, it can be more physically challenging as well. You can imagine if you're meeting people that are acutely unwell, they can become quite distressed, and they might become aggressive verbally or physically and things. We do have a lot of support around us, and I find that because it's quite challenging, the teams that you work with, you do end up being so supportive to each other, because you've got to get through it some way, and everyone is really good about that. But obviously, if that's not the kind of thing that someone thinks that they can, not everyone can have someone scream in their face and not react.
Yeah, fair point.
We all know that it's not for everyone, but that's why there is the different working environments, either community nursing or children's services. There is lots of different places to be, and obviously the liaison nurses in hospital do play a massive role in helping to support ward staff and even like carers of people when they're in hospital, because unfortunately I'm not sure that general nurses get as much of an overview of learning disabilities as perhaps learning disability nurses would like them to. So that's where we can come in as well, with helping to educate people. So I'm not sure if I actually answered the question, if I went off tangent.
You did. But it gives us an insight into and for students into what kind of settings are you going to be working in if you take one of these different roles. And it's important to know that, because it can be confusing and it can be daunting to think, well, where am I going to work? What is it actually like? Is it in a hospital? Do I go and do home visits? And actually, is it more varied than I think it is? Now with John, I mean, I think maybe I'm being a bit simplistic, but I think it's quite obvious that being an A&E nurse, you work in A&E, right? You don't go and do home visits. Correct me if I'm wrong, but also then talk to me about the other role that you do. Let me understand a little bit more about that. Working on, you said it was on the education side, is that right?
Yeah, you're right. A&E, you just based in A&E, you don't do home visits or anything. But there are teams that do it in adult nursing anyway. But with the education role, so my job title is a student education facilitator, and initially it was dealing with pre-registration students, whatever route they take. In EPUT, they also run apprenticeship schemes, level 5 schemes for an associate practitioner role, as well as apprenticeships, and obviously people taking a traditional degree route as well. So originally my role was to sort of support them in practice, any issues that arise, anything like that. And then we also sort of have our own workshops that we do for the trust, because there was a change to the supervision of students. It's called a SSSA, which came into place in 2019, implemented in EPUT. So they were sort of helping to people understand that. And then we also sort of had other little projects we were running ourselves to do with education. I was training on some clinical skills because I quite enjoyed doing that. And then in January, I got asked to write a program for international nurses to train them for, they have to do something called an OSCE, which is an exam, like a practical exam. And I wrote that, and now we're running it. We've got 70 over at the moment training with us altogether. And then that sort of become a part of my role as well now. The education role, I just sort of fancied doing something on the side of A&E. I fancied a bit of a change. I get quite bored quickly, and I need change and a lot of variety. That's why I started working at A&E. And I just thought I'd go for it, see what happened, because it was a progression for me, and it was quite a quick progression in the time that I'd already been qualified. Luckily got it. They agreed to do both part-time. I started doing that. I really enjoyed it. And I'm really enjoying doing this now. But it's not just the training, we also do the support. Like, we had a couple start on the ward this morning, so I took them onto the ward at 9 o'clock this morning. And fun enough to see an old colleague of mine on one of the wards that I didn't know she started working there. And then we do the training, we do the support, we assess them one-to-ones, but also we support the permanent staff, like the managers, if they've got any questions, and just general things. And some of it isn't exactly what I thought it was going to be. Like, I do a health and safety report. Didn't think it was my role, but it's a very variety of sort of stuff that comes your way, really. But I mean, the education stuff I really enjoy doing. I love teaching them.
Brilliant. And it's good to see that there's a role for everybody, because again, some people do like that variety and that change. I'm kind of similar, and you get it. And I love the fact that you managed to say that, you know, A&E wasn't busy enough and not stressful enough, so you wanted to get more in on your schedule in your daytime. That's quite impressive. So I tip my hat to you. But for students, look, understand that there are options. There's very different things that happen within an organization of this size, and the different nursing bits that we were talking about. The other thing that I want to say is that, have you all noticed, and you will have done because you'd have been on other sessions, that the amount of times the word support pops up, and support from this person, support from this team, support from here, you will notice that pops up a lot because of the way that the nursing and this area works. Is you have to support each other and work together, otherwise nothing really goes forward. And I know that as students, you may sometimes feel worried about, well, how do I integrate into that kind of environment, because it is busy, it is not easy at times. But the thing that you need to understand is that you are given support. People want you to come in. So with that, I'm going to ask Ellie, okay, so you do what you do, you are where you are now. Think back to when you were a few years ago, 15, 16, and the students that we got on now. What would you say to them, or what would you like them to know if they were, how would you pitch your career or your department or where you work? What would you say to people, and what are the characteristics they need? Not skills in terms of good at maths and science, but what are the little character traits that they need that would make them successful?
The most important thing about coming and working where I work is empathy, caring about people, genuinely caring and wanting to support them during that time. Is way more important than any maths or English skills that you would have. And just don't be worried, because there will always be people there to support you. We love having new people come and work with us. We love training new people up and supporting them and hopefully helping them. And I love it when we have young girls come in who then progress on to go and do their midwifery training. Some have gone on to paediatric nursing, and it's lovely to be able to see them progress through their careers. I feel like I'm a bit further on in my career and I'm kind of looking back, but don't be worried to take a chance on something, because what you pick as your career now is not going to be your career for the rest of your life. I don't think many people now have a career for life, as was always thought of in the past. I think people move on and chop and change depending on where they are in their life. Totally.
Absolutely true. I can attest to that. Fantastic. Thanks, Ellie. Rebecca, same question to you. And also because I suppose within your story, you've got that personal connection. And one thing that I want to touch upon is that because you had that personal connection and that experience when you were younger, did that also help? Doesn't mean you have to have it, but that, I'm guessing that did help when you went into LD nursing, make you understand things a little bit more, right?
Yeah, I think it did sort of give me a starting block to know exactly what it was I was looking to do, but I don't think that is required. I mean, speaking of the people in my team, no one else is in the same situation as me. So there's obviously other things that do draw people to it. I think that, again, empathy is a big part of it. Obviously, it is with any nursing, really. Communication is a massive skill that's needed with learning disability nursing. Obviously, some of the people we work with may have different methods of communication and may present with behaviours because they're trying to communicate something. I think the people it's the basic thing of wanting to make a difference. And I think that is really important. It's just trying to make the world a better place for everyone, really. And that is what all nursing and healthcare and everything is about. Obviously, people with a learning disability are amongst the most vulnerable in society. And I feel that we need to do what we can to level the playing field, prevent the health inequalities, prevent people from learning disability from die younger for no reason. And yeah, I mean, I hope that learning disability nursing will continue to appeal to people from the future, because people with a learning disability aren't going to go away, they're only going to increase. And obviously, we need to make sure that we can let people access services and live fulfilling lives and be as independent as possible.
Fantastic. And that's a brilliant point as well for those of you that are looking at these areas. There will always be need, and it will increase. So there are always going to be opportunities, which is why you are here. And I'm going to come to John last because we're almost ready for lunch. And I have got a question. So it's going to tie into John, the question I've got. But the other thing I want to do is, if you feel confident enough as a student to do it, you are here today on a session about nursing and midwifery and routes into nursing and the different types of nursing. If you feel confident and comfortable sharing it with the group, can you put into the chat box why you are looking at this area? What particular thing is it? Is it about making a difference in people's lives, or is it a different reason? What is it? Put it in the chat box for us before we go to lunch, if you feel comfortable doing so. But then again, John, same question to you in terms of like those traits, because these are three very different types of nursing, and you've said about your need to always be, I suppose, have something interesting, or your attention changes. So being an A&E kind of fits for you. And then I'll get to the question in the chat box. So yeah, so what are we looking at with that type of thing?
I think the main thing for me is resilience. I think you're going to come across a lot of different challenging situations, traumatic situations. And resilience is important, but it's also, and I know you said before about the support you get there is really well managed, in the sense that we could have something quite traumatic happen. I mean, to put it bluntly, people do die, and it does happen. It's quite common. Well, not really common, but it's just, knowing who to sort of lean on with that. Usually with other colleagues that you can chat about it. It's something that we do called a debrief, which is really important, and I'm a massive advocate for that. But just being resilient to the busy environment, the sort of things you come across. You could have someone who is intoxicated on many different things screaming at you that, don't take it personally. It's just a condition, just the way they are. Know who to speak to. And also just be willing to learn. And I think that's quite relevant in sort of all aspects of not just nursing, in healthcare. Even when I've qualified, I've continuously been doing learning. I've recently done a course that I wanted to do called Advanced Life Support. There's always courses coming out, but that having to always learn, and it's not, I'm saying you've got to go back to school all the time, but there's always learning opportunities. Even certain things, like I can have someone who's been qualified longer than me, more senior than me, that will come and ask me a question about how a certain medication, because they've just forgotten or they haven't done it for a while. So just little things like that. Always willing to learn, always willing to impart knowledge as well is quite important.
Brilliant, fantastic. And then the question that we got in the chat box, and I hope this is kind of your area. Well, maybe it's not, but Sarah wants to know, if you're thinking of doing nursing and then getting into medicine, is it possible to still be able to do medicine after doing nursing?
Yeah, definitely. There's actually a couple of doctors I know that started off as nurses, and usually it's some sort of postgraduate degree. So once you've got your degree, you do a postgrad in medicine, and I think it's just the 2 years of medical school, and then you go on and then you become like a foundation year 1 doctor. I think that's how it works, because you've already got a degree. And if you want me to be honest, it probably helps you out a fair bit, because we will learn from doctors as well as they learn from us as well when we're working in the environment. So, the anatomy and physiology, yeah, we do learn it at uni, but we really get grasping it in a clinical environment. So having that experience probably helps. But you can also, if you didn't want to go directly into medicine, but you want to become more advanced, there are advanced practitioner courses that there's one called an advanced care practitioner, and they're on the same level as a foundation year 2 doctor. So there's that option as well. And obviously from there, if you feel like you're comfortable with that, then you could probably go and study medicine. But even they prescribe, they diagnose, they treat, they can admit, they can refer, and do the same as FY2 can do. So you've got that option as well.
Brilliant. So there you go. There's the answer to the question. It is possible and it can be done. Right. Look, it's 11:58 and we are ready to go to lunch. But I want to say, and like Sarah's done, say thank you to Ellie, to Rebecca, and to John. Unfortunate that Alex had to be called to a meeting, but we are meeting her later, so that's absolutely fine. But thank you to the 3 of you for coming along, spending the time to share your experiences and share the information and your career routes as well. So hopefully inspire some students on here to get into one of your roles or into just one of your hospitals or organizations. It's brilliant. So thank you very much for it.
Thank you.
Okay.
More than welcome. It's been great to hear all the different scenarios as well. I love it. But yeah, so look, that's really important to be able to hear from people who are doing it already, and to be able to hear what's important and what kind of things do we need in terms of personality traits and what can we go on and do, and those different options that open up, and understanding that there is support and there are different pathways that you're going to find out about later on in life. You don't know everything now, but go and try it. Okay. So what we're going to do now, we're going to go for lunch. We've got lunch until 1 o'clock. Do not disconnect. Stay logged in. Keep your camera off. Keep your microphone off. I'm going to keep the session running. The session will continue to run. I'm going to turn off my camera and my microphone. I'll be doing work in the background. I'll go and get something to eat. Stay on. And then we are going to see you after lunch. And remember, this afternoon after lunch, we've got the case studies and the activities, midwifery, nursing, and then we've got the larger Q&A panel. So keep thinking about questions that you're going to be needing to have answered. And we will see you after lunch. So see you at 1 o'clock. Come back a couple of minutes early and we'll get going. So thank you very much. See you all soon.
Thank you. See you at 1 o'clock, sir. Bye, Max. See you at 1, Max. So.
Welcome back to this afternoon session. Actually, what I'm going to put up first, we've just had lunch. A few people have had some interesting stuff. Now, if you're watching the recording, you probably won't have had lunch. You'll have just gone straight through, which is fantastic. But yeah, we're back. We're back for the afternoon session, and we're going to get a little bit interactive. Well, we're going to see some case studies and do some activities. Just to remind you quickly of the agenda, we've done the morning bit. We did the speed meets, which was fantastic. Now, Alex was supposed to be in the speed meet, but as is the nature of the work, she was called away. But we are going to meet Alex this afternoon. So we'll get to see what she does and hear a little bit about her role. But this afternoon, we're going through those activities. We're doing the 1 till 2 session activities, nursing and midwifery. How much do we know about midwifery? I'm learning as we go along. And then we've got the Q&A panel, 2 till 3, with the overview and the wrap up. Bring the questions. Bring as many questions as you like. Speakers from this morning will be coming back to this afternoon. And I know that some of the sessions, we didn't have much time to answer questions. So let's get those questions in today. You can even start putting them in the chat box now in case you forget them, so that they're there and ready to go. Right. So we are moving on to activities and case studies. The first one, I believe, let me get back to the right slide. Looking at midwifery case studies. That's going to be Alex. So Alex, welcome back. How are you?
Hi everyone. I'm so sorry that I had to dash earlier. It's really lovely to be here and spend some time with you all. So just a bit of background. My name's Alex. I am a midwife. I started training in 2009. Like I mentioned earlier on, I did not have a clue what I wanted to do when I left sixth form. I didn't know what I wanted to do as a job. I'm still kind of thinking, what do I want to do as a job? Because hey, does anyone stick in the same career? I get bored really easily, so I like to mix it up every couple of years, which my family find quite interesting. So I was a direct entry, so I'd completed my A-levels, went to university, I went to ARU, very lazy. I just wanted to stay at home so that my parents could carry on cooking me dinner. I could live at home, I could keep my car, just helped with me. I liked the idea of training in a organisation close to where I live so that I could work there in the future. So then I started working at Colchester General Hospital as a Band 5 midwife, which means you rotate around the whole areas of maternity. So you work on the wards, on delivery suite, in community, in triage, and then you become a Band 6. Unfortunately, before I got to my Band 6 status, my husband was relocated down to Plymouth. So we upped and moved down to Plymouth for a little while, which was great actually, because it was a tertiary neonatal unit level there, which meant basically the neonatal units are banded 1, 2 or 3, and depending on how premature or how unwell a baby is depends on what unit they go to. The higher the level, the more unwell and more sick they are. So I was managing to look after women and see cases of infants that I'd never seen before. So that was really great. I learned so much by working down there. And the geography is very different in the southwest. So if you've got a level 3 unit, everyone tends to go to that one unit. So really did see some very interesting things while I was there. But it was too far from home, so moved back up to Colchester. And I've done a variety of different roles since I've been a midwife. So my love and my passion is delivery suite. I love the adrenaline. Everything's different every single time you come onto shift. So I was a delivery suite coordinator, which meant I help allocate the workload, support the staff whilst on shift. And then I'd done that for a little while. I then moved into the practice development midwife role, which meant I supported the midwives with their training and further education. And I'd done that for a while. And then I was a matron for a little bit, a quite short amount of time, only 9 months in the matron role, but that gave me great oversight of how to help run and support a unit as a whole, rather than just thinking about an individual area, really looking at the local and national reports that have come out and how our unit was meeting those. And then more recently, I have moved into my current role, and I'm currently working across the integrated care system. And I was very, I didn't know what that was. So basically, the integrated care system is anyone who provides health and social care within a geographical area, all clubbed together, and that's called the integrated care system. So I work across Mid and South Essex, so that not only includes the acute trusts at Broomfield, Basildon and Southend, but it also includes primary care, GP practices, mental health, community services, social care. So I'm looking at students across the patch to see how we can make the learning environment the best it can, so that when you're doing your courses and you come out on placements, you're having a worthwhile, valuable experience and you're meeting your learning outcomes. So did I think that I'd be doing this role when I first started my midwifery career? No, I didn't. Am I loving it? Yes, I am. Will I be doing this forever? No, I won't. I'm very honest. You can ask me any question about midwifery and I will give you my honest answer. But I am someone who gets quite bored quite quickly, which isn't great because it drives my family crazy, especially my husband. He doesn't know whether I'm coming or going.
But the brilliant thing is the role is really diverse, and there's so many other things that you can do and explore. So if you're like me and you just need to be kept on your toes all the time, you know, midwifery, nursing, any healthcare profession really does that for you. So I'm sure some of you have got questions for me, but we have got a few slides now, and I thought it'd be a good opportunity to go through case studies so that you just had an idea of what a midwife does. And then we can save the questions till, here's one already. So what's the hardest part about midwifery? I'll cover that on my last case study, if that's okay. Okay, next slide,
Alex,
please, Max. Yes.
Before you go on, what I'm going to say is, look, I love the absolute honesty that everybody has and that has on these sessions. And when you hear what Alex just explained there, what we want you to understand as students is the reason why my job exists is because that's how life goes, right? You don't know what you're going to be doing you can plan, but things change, and it's nice to be honest and open about it, because what we don't want you to think is that as adults that we have all the answers to everything and know amazingly exactly what we're going to be doing, when we're going to be doing it, and how we're going to be doing it, and that we've made the absolute best decision straight first time round. That's not life. So take the pressure off yourself, listen to what people are saying, learn from their experiences, and go out and explore yourselves. And don't be afraid to change your mind, to change course, to do something different, to try something different, because what you love now, you may not love anymore in 5 years' time, and life changes. So roll with it, but listen to the experiences, and that's how you get the best thing. So to everybody who's on the session, just continue to be open and honest, because that's what students need to hear. So thank you.
Oh, thank you. Okay, so when I came into midwifery, what did I think it was going to be? I honestly thought it would be working shifts, based in a hospital, probably delivering some babies, maybe providing some care to ladies on the postnatal ward. But actually, midwifery is a whole load of different stuff as well. It does have that. Those elements are definitely there, but there's so many more roles within midwifery. So some of you may have seen Call the Midwife. I've never ridden a bike. I don't own a bike. Yes, we serve our local community. If you're attached to an organisation that's close to home, I don't wear a belt with my uniform. I don't have things in my hair. So try not to see the things that you see on telly and take it at face value. The same is said for One Born Every Minute. I watch that programme and I cringe. Some things happen like that, but let's be honest, they're trying to get people to watch the programme. So midwifery, if you take the word midwife, it means to be with women. Our role as a midwife is to empower pregnant people, pregnant women, to make the best choice that they can for them. We are there as support. We're there to provide information. We're there to empower people to make their own choices about the care which they wish to receive, and that's right from the start of pregnancy, when they get their first pregnancy positive pregnancy test, all the way through to when they're at home in their community, and up to 6 weeks postnatally. So it's not just about delivering babies. We have midwives who are within the screening role, so they lead on screening for infant and newborn conditions. We then support women alongside obstetricians when difficult decisions or choices might be presented to families. There are midwives within education roles, which is something that I've done. I'm quite passionate about education. So again, yes, you're there to support women, but you're actually supporting the staff who are doing that. Infant feeding roles. There's so many different bereavement roles within diabetes. The role is really quite diverse. So if you had an interest in a particular area, it is something that you can always go and specialize in. Something which I particularly love, and I don't think as a delivery suite midwife we saw it that often, is continuity, but I know that's a massive national agenda, is to have continuity of carer throughout pregnancy. The rationale for that is, I'm sorry, someone's knocking at my door, and it's my back door, which is a bit concerning. Bear with me 2 moments while I shout to my husband.
Don't be afraid to keep putting more questions in the box, because we will get to them at the end and we're moving to the Q&A.
Sorry, guys.
That's all right, no
I
worries.
think I'm really unprofessional. I do apologise. So Ben, they're at the back door. Yeah, sorry. We don't even have access to our garden, so I have no idea how someone's in our back garden. Anyway, we'll deal with that in a moment. Continuity of carer is brilliant because you see the same women, the same family from the start of their pregnancy through to the end, and you build up that relationship with them, so you get to know their concerns, their worries, what's important to them, and that's going to be different to every family that you look after. But you also can give advice and recommendations that they'll want to hear, or put in a phrase or a way that they understand. And a lot of midwifery is about communication. It's about actively listening to someone, really hearing what they're trying to get across, and then supporting them the best way that you know how to. Thank you, Max. Next slide, please. So it's about putting an individual right at the center of all of your conversations, all of your thoughts, all of your advice, and making sure that the information you're providing them and the care that you're giving them means that they're being looked after emotionally, psychologically. You're thinking about their social well-being, not just their physical needs, and really empowering the pregnant person in front of you to make their own choices about their pregnancy, their birth, and their postnatal care. So it's not dealing with sick people. Generally speaking, midwifery, we care for and this is a very general statement, but young, fit, well, pregnant people who are going through a normal life event. And yes, people are having more complexities now. People who are having babies now perhaps more have health conditions than, say, 15, 20 years ago. But that's only making the role more exciting. You're learning more things every day. But it really is about giving women and pregnant people their power to make their own choices about their care. These are fit, well people who are going through a normal life event, and we just need them to feel empowered to make their choices. Thank you, Max. So I'm going to go through 3 case studies now, if that's okay. Please feel free to get involved. If you want to come off mute, please feel free to chat. I am not afraid. The only thing that I'm conscious of is the time. Or put some comments in the chat there. So first case study is Sally. I have changed all of the names to keep confidentiality, obviously, at all times. Sally was a lady who we looked after within my local trust. She was a 31-year-old female. This was a planned pregnancy. We first done her booking history at 9 weeks pregnant. She was normally fit and well, and her physical state, she considered herself healthy. She had suffered with anxiety in the past and was on medication for this with her GP. And pregnancy, although it was planned, can be quite a scary event for some people. Everyone considers it, a lot of people consider it to be this normal event, but actually if it's something you're feeling particularly anxious about, whether it's planned or not, it can be quite a heightened time. And there's a lot of emotions, and obviously hormones are going everywhere when you're pregnant. So it's really important that when you have someone in front of you, you're shaping the care that's appropriate for them. So thank you, Max. So for Sally, the really important thing for Sally was that she felt she had some control. Pregnancy, there's no control with pregnancy. What happens during the pregnancy or the labour is out of everyone's control. However, it was really important that Sally felt she had choices, and that the choices she made was within her control. And for that, people need to have information that's up to date and correct. And evidence-based. So we made sure that we gave lots of information to Sally about the symptoms of pregnancy, what happens in common pregnancies. So she had a bit of awareness before things might happen. So the different changes and feelings that she might have with her body. Making sure that she had good, reliable resources and apps and resources that she could go to that are appropriate. So we all know that Google is not our best friend with anything to do with health. However, the internet's an amazing resource, and actually let's use it for the positives. So we've got some fantastic maternity apps. So let's point women and pregnant people in the right direction of that, so that they are using reliable information. It was really important to set realistic expectations for Sally so that she knew what to expect throughout her pregnancy when she was seeing healthcare professionals. So when she was going to see her midwife, and it was really important for Sally that she saw the same midwife over and over again, so that she didn't have to keep on explaining her story, keep on explaining her anxieties, so that she could make that relationship with her named midwife. Making sure that if she needed to have any other appointments, she had them. And for Sally, we did do a referral to the mental health specialist midwife and made sure that she was on the radar, because she had anxiety prior to pregnancy. We wanted to make sure that that didn't develop into anything more throughout the pregnancy or during the postnatal period, and that actually she had other support available to her if she was to need it, and then, you know, it wouldn't waste time later on down the line. And it was really important that for Sally's wider family that they all had antenatal education, so that it wasn't just Sally preparing for the arrival of their baby, but also her partner and the wider family. So it's great, generally speaking, people within our communities have wider support, but we also need to think about families who live perhaps within the barracks. Have they got local support to them? Are their families actually up north and they don't have any connections down here? Are there any support groups we could get them in contact with, so they don't feel alone and isolated when this baby arrives and perhaps their partner's out on a posting or something? So it's really thinking about what support network did Sally have, and pointing her in the right direction of making sure that after she was out of our care, she still had a good support network for her. So I hope that this case study shows that it's really individualized, and actually you take into consideration lots of different needs for the person who's sitting in front of you, and it's not just taking on their physical being, but also thinking about their mental well-being and their social well-being as well. Thank you, Max. So the next lady, I looked after Susan. Susan was 28 years old. This was her first pregnancy. It was planned pregnancy. It was fairly straightforward. She didn't find the pregnancy particularly challenging. She was well mentally and physically. She'd had a midwifery-led pregnancy, so she hadn't needed to see a consultant or an obstetrician throughout the pregnancy. She was 38 weeks and 6 days, and a normal term pregnancy is considered between 37 weeks and 42 weeks. We midwives normally work in weeks rather than months. I know everyone goes, oh, how many months are you? But generally we talk in weeks. And when you're coming to the end of your pregnancy, you would expect your baby to be head down, as in the baby's head is in the woman's pelvis, because generally speaking, babies are born head first if there's going to be a vaginal birth. Sometimes babies don't decide to go head down and they are bottom down, and this would be called a breech presentation. And Susan had a breech baby. There are different things we can do, different options for women. Sometimes, so the options are don't do anything at all, and a woman might have a very informed discussion about a breech birth and the risks and benefits involved with that. We can perform an external cephalic version, which is where an obstetrician will pop their hands on the woman's abdomen and rotate the baby manually. And with the idea being that the baby will then become head down, or the lady can decide to have a cesarean section, but those also come with their own risks and benefits. Or she can have a vaginal breech birth, which we don't see very often these days. So percentage wise, about 3% of all term babies are breech, so it's not a common occurrence, and because of the risks associated with a vaginal breech birth, often a ECV would encourage the baby to be turned is the first option that we would go for, but sometimes cesarean sections are required. Learnt form of how they used to do before sections from Call the Midwife. Yes, I think I've seen that one as well. It's really interesting to watch. So thank you, Max. Susan came into delivery suite and we were going to perform a external cephalic version, and they can be a little bit uncomfortable. And Susan was really unsure whether she wanted to have it, because why would you want to put yourself through discomfort? She didn't know even if the baby did turn to be head down, whether she then wanted a vaginal birth, because she had really thought that the cesarean section was going to be the way that she chose to have her baby. And she was really anxious when she came into this appointment. And you'll see here what we've done for Susan. You'll see time mentioned multiple times, because it was really important that it was the first time I was meeting Susan. She'd had her whole 9 months where she'd been doing this with her multiple different midwives in the community. And I didn't know her priorities. I didn't know what was important to her. So it was really important that we just had time together to chat through what was most important for her, and what choices were available for her. So I done that, got them a cup of tea. It was important that this decision was made with Susan and her partner, because it's their pregnancy together, it's their baby, and that actually they didn't feel influenced by a particular decision by my preferences or the obstetricians. So the obstetrician came in and gave some information. Then the obstetrician left, and I done a bit of a translate service to go from the jargon of an obstetrician to actually a lay person talking about what her choices are. We gave Susan even more time. Normally these someone coming in for an external conversion would normally be in for 2 hours. Susan was in for 7 hours. We gave her loads of time. And then, you know, it's really important to reassure her so that she knows that whatever decision she made, she didn't feel coerced or bullied into making it, and actually she was comfortable with her choice. Susan found it quite emotional. She needed a lot more time to think about her options, and she needed someone to be with her to go, it's okay, to, you know, make that choice and that choice be right for them. Susan left after 6 to 7 hours. She didn't have an external cephalic version because she didn't want it, and that's okay. Just because that's the advice or recommendation from an obstetrician doesn't mean that that's right for the individual who's in front of them. And she left with an appointment to then be booked for an elective cesarean section, and that was her choice. And I think we need to think about, as a midwife, that what would be the choice and considered normal for one person isn't for someone else. And actually we meet so many different people throughout our career, and every day you meet someone new, that everyone's perception or decision is going to be based on their interpretation of something, and that actually what's right for someone won't be right for someone else. I know Susan went on to have a lovely baby boy. They were very happy, and I managed to see them on the postnatal ward, and it was lovely because, and afterwards she thanked me and said, thank you so much just for the time. And I think it's really important that people don't feel rushed into a decision. I know when we all go and see a GP, we've got a 10-minute appointment. You know, everything has to be quick with the NHS, and in some respects maternity does as well, because when they see their community midwife, they have limited time. However, at that point, Susan really just needed time. She needed all the facts, and then she needed someone to go, it's okay to make whatever decision you want to do. And so if you take anything from this case study and you're thinking about applying for midwifery, think about what transferable skills you have to demonstrate that you can actively listen to someone, and you can make sure that their priorities are your priorities at that time. Thank you, Max. Okay, so my last case study is something which I find quite challenging within my role. And before I became a midwife, this isn't something that I considered anything to do with midwifery, and it really opened my eyes. A bit personal history of me, I didn't have any children when I came into midwifery. You don't need to be a mum or a dad to be a midwife. You can support pregnant people, whatever your background is. And I think I was probably quite naive. I hadn't thought about bereavement or the loss of a baby before I started my training. And even now, I still find that's quite challenging to even get your head around, because in our country, we're so fortunate that actually pregnancy, generally speaking, ends with a happy outcome for mums and babies. But unfortunately, sometimes it doesn't. So in Sarah's case, she was a 17-year-old. She had an unplanned pregnancy. Her and her boyfriend were very young. They were still at school or sick form, and it wasn't planned. However, they had great support network. You know, they had decided to continue with their pregnancy, and they had decided that actually this is something they wanted to continue with, and they had great support of their family, their immediate family and their friends. Sarah attended a routine antenatal appointment with her community midwife at 32 weeks, and following some of the examinations, they noticed there was an irregular heartbeat with the baby. So Sarah was referred up to the consultant-led unit, and that's where I was working. That's where I met Sarah. And when she came into delivery suite, it was found that the baby had a condition called fetal hydrops, which is a condition which affects multiple different organs throughout the body, and it's the ability to manage fluid. And unfortunately, the baby had lots of fluid in areas where it shouldn't have. And usually, this is caused by an infection earlier on in the pregnancy. It is sometimes undiagnosed, and usually it's fatal. And unfortunately, in this case, the baby wasn't going to have a good outcome. So Sarah was informed of this with all of her family. And obviously, when you've gone through a pregnancy for 32 weeks, you're nearing the end and you think, oh, I'm going to take a healthy baby home. And this was quite a shock, not only for Sarah, her partner, but all of her support network. And again, bereavement and the death of a baby isn't something that you expect, but you learn how to best support these families. And it was really important that, again, Sarah had time to process all of the information that she'd been given, and time to think about her options. Unfortunately, before she could make any options, the baby passed away while she was still pregnant, or she was on the unit, and while she was actually there was nothing that could have been done. Unfortunately, the condition was too severe. But what we were able to provide care to her afterwards is something which I think only made the situation a bit better. Thank you, Max. So most obstetric units have a dedicated suite for bereavement services, because unfortunately late miscarriages, termination of pregnancies for fetal abnormalities, and sometimes the death of a baby, it does occur. It doesn't occur all the time, but it does occur. And it's really important that there's specialist areas for those families to be able to process what's happened, spend time with their babies, make sure that they can make memories with their babies, make sure they have individualized care. If they want to have the baby blessed, if they want hand and footprints, it's really important that as midwives and healthcare professionals, we can do everything in our power to make that time as special as possible. And making sure that once it's the right time for that family to say goodbye to their baby, that there's support groups and support for that family after they've left our care, so they don't feel isolated. They realise they're not on their own, and they have other people that they can turn to and talk to, because society and media and the way that we live now, everyone posts stories about how they go home with a healthy mum and a healthy baby, but unfortunately that's not the case for all people. So in response to your question about what I find hardest, I find bereavement within maternity the hardest, because as an 18-year-old going into midwifery, I was naive and I didn't think that occurred. It hadn't occurred to anyone that I knew before. I still find it hard. The thing that I find hardest about it is knowing what to say. I mean, what do you say to someone like that? And I think anyone who comes into health and social care wants to provide amazing care to the people in front of them, and they want to leave knowing that they've had a positive experience. If someone's unwell, you want to make them better. If someone's uncomfortable, you want to soothe them. And in situations like this, you can't do anything to make that better. However, what you can do is provide certain emotional and you know, support, so that actually you're making the best out of that situation. Every day is a learning day, and every time I look after a family who's gone through a bereavement, I learn something different, and I phrase something a different way and think, oh, that's worked better that time. But I still think that these cases don't leave you. I remember Sarah, I remember the baby's name, I remember the family, and yes, you have that with every family you look after, but there's definitely more cases where they sit with you for a little bit longer and a little bit. You just carry them in your heart. I think that's the thing. I think I've gone over my time. I'm really sorry, but I just really wanted to tell you that midwifery is so diverse. Generally speaking, you're dealing with healthy mums and healthy babies all the time, but there are curveballs every single day. No day is the same, and that's whether you work on community or delivery suite. If you want literally diversity, then this is, you know, the profession you need to go into. And yeah, I will be here for all the questions. I think you've got another lovely guest speaker coming up now, so I'll be quiet because I can talk for England. And then if anyone's got any questions for me, please fire away later.
Fantastic. Yeah, no, that's absolutely fine. It's only a couple of minutes over, and you did have to do your introduction from before, so that's all cool. Look, we're still on time, and that's really good information as well, and shows you again another side to what we're talking about today. Alex has just mentioned there that she will be around for the Q&A afterwards. So with some of those questions coming in, do keep putting them in, and we will get to them, because remember, other people are coming back for that as well. So that's brilliant. So you've met Alex. Now we're going to meet Tash again. Did we meet or re-meet?
Re-meet, yeah.
We met you this morning, obviously, and you spoke to us this morning about the university route into nursing. And now you're going to give us some nursing case studies. So, yep, you do your best, Professor Whitby, and I'll change the slides.
Oh, thank you. Oh, how can I follow Alex? That was excellent. I hope you all enjoyed that. I must say, looking at the chat and that, it's really good to see some really insightful comments and questions there about midwifery. And I'm not a midwife, so, you know, it's been a, you know, education for me. So it's really important. So the first thing, you know, we want to talk about this afternoon is that nursing care studies. What we're going to do is just go through some of the case studies. You know, it's going to be a little bit different to Alex's approach because we do a different job, and it's nothing to say the nurses and midwives are completely different. Yes, there's some fundamental values around our care, our compassion, our morals, our ethics are very shared, but actually the job roles are very, very different. And you know, you can't, it's like, you know, someone said to me, oh, could you not do a joint midwifery and nursing qualification? No, you can't, because they're separate. And so it's really important that we do see them as two distinct roles. So next slide, please. So I've got a big sort of wordy description there about what is nursing, and we've come up with that word again. I'm not going to test you to see if you can remember what autonomous means, but it is, nursing encompasses everything, that autonomous, a collaboration of individuals, and it cares for all ages, all families, groups, communities, sick or well, in all settings. We don't just look after poorly people, we don't look after ill people. One of the fundamental things about nursing is around health promotion, health advocacy, and also it's also caring for people in the last days, last months, last years of their lives, when they do have a life-limiting condition, or they have actually come to the end of their life for whatever reason. And it's important that it's not all about what you see in things like A&E, you know, when you say watch on a casualty, Holby City, those sorts of things. There's a reality that extends beyond that style of nursing. Okay, so it's about, you know, that collaboration between all different professionals. So to give you an example how we could collaborate, for example, Alex may have a pregnant woman who is, you know, in her first trimester, who, for example, has existing mental health problems. There'll be specialist support for a specialist midwife as such, but they may have to collaborate with the mental health team regarding her medication regime, because that might affect the baby. So it's about how they can support her through this time in her life. It's not an illness, it's a normal part of life. But because that person may have existing mental health problems, people and nurses and midwives have to collaborate with each other to ensure that the person that stays focused is the patient or the pregnant woman at that time. Okay, so next slide. So we talked a little bit about this morning, about what we think about when you hear about nursing care. So I've just put a few pictures up there about, you know, the things we think about, and I've just, obviously these are just a variety of different pictures really, and it's around, you know, not just about when you see blood and gore and all of that sort of thing, because that seems to be a perception of what we see, but it is around, you know, we can see there from that picture at the top left hand side, you know, there's a picture of a person just talking to someone. Now, that conversation is done with compassion. That conversation might be just a general conversation about that person's day, but that conversation may be talking to someone about their diagnosis. It might be talking about the fact that they might want to change their eating habits because it may be contributing to their health and well-being. So it's about that. It's a lot of the things we do are around conversations. It's not just about the things we touch and do and those sorts of things. And it's similar to the lines of what Alex was talking about. We share those same skills in communication, in advocacy. That patient-centered approach happens in both roles and professions, but obviously it's distinctly different. Okay, so I'm going to go on to the next slide. So going on that themes of sort of like that compassion and what we can do to each other, what I want you to do is have a look at this picture that's on this screen. All right, this isn't a real patient, it's been mocked up. Okay, this is one of my colleagues who will probably not forgive me for showing this to you all, but this is a picture of one of my colleagues who we were doing some work and we want to do a spot the problem issue. Now, thinking about what I've just said about what nursing is, I want you to put in the chat about what do you think is wrong with this person in terms of what could you do for them to make them feel better. Okay, so just looking at the photo, it's quite a small photo I know on your screen because of the screen share, but what could we do as nurses that you can see? Excellent. So the first person in was Chloe with her, yeah, she can't even reach the mug. Now, the thing is of that not being able to reach the mug, you know, she therefore is not going to retrieve adequate hydration. Now, our roles as nurses is to make sure that we actually do ensure the people in our care are adequately hydrated in whatever situation we may be in. Her position, you can move the table close, cover her toes so she's warm and comfortable. I don't know about any of you, I hate having my toes out. Okay, out of bed at night. So that would actually stop me from even sleeping. And we know sleep is important to someone's recovery. We could adjust their glasses. Yeah, move her up the bed. Maybe a privacy curtain. Obviously, it's not a real patient in the bed next to her. That's actually a mannequin in the skills laboratory. So yes, we could protect her privacy. If we go on to the next slide, you've got most of them. So one of the things I put is her feet. So someone said about covering up her toes. If you notice something about her toes, they're resting on a hard piece of plastic. Now, as nurses, we would not want that because that person could actually end up with sort of wounds on the bottom of their feet because their feet are touching that piece of plastic. And if that person can't move themselves because of their health status, that person will have that pressure on that part of their foot for long periods of time. So someone actually said changing her position, sitting her up and move her up the bed a bit more so she can lay comfortably. It will make her more comfortable, but it would alleviate that pressure on the base of her toes. So yeah, so can't reach her cup. Her hair needs a brush. Yeah. Now, so all of us as individuals like things a certain way. Okay, you're all teenagers. You know what you like in your life, how you want to feel, how you want to look, how you want to be. And sometimes that's difficult to ascertain. But on the whole, if it's in our power, we make sure our hair is exactly how we want it to be, depending on the activity that we're doing today. So, for example, if you're going out one evening with your friends, it's important that you look a certain way. And that will make you the person that you are. Now, this person in the bed, you know, her hair is all over the place. Now, if that was me, having my hair not in the way I want it to be is very, very important to me. Don't worry about other things, but every person has got something that's important to them. And this person in that bed also has that thing that makes it important to them. So it's important that we try and make that person, even though they're unwell, be able to exist as the person that they are. So that might mean, you know, sitting her up in bed. It will mean making sure her hair is how it wants to be. You know, she's in a hospital gown there. She might want to wear her own pajamas or her own nightie or her own clothes. And that's what's really important to nursing. And they're the things that you don't often see when you talk about nursing, is those types of things that are all part of the nursing role. And we work as a team. So it might be you as a registered nurse, healthcare assistants, people that we've got apprentices working in our area. We all contribute to make sure the patient is at the centre of our care. As I say, bedding's a mess. I can't bear my bedding, or even at home, being all messy on top of me. I like to, even this hot weather, I like it all to be neat. So it is about looking at those softer skills that are, in my view, more important sometimes than some of the other skills that we're taught. Next slide, please. Thanks, Max. So we're going to move on to one case study. So if you remember from earlier, I've had quite a varied career, really, and some of the experiences I've had have actually come from where I have done things in my own life. I'm actually a scout leader, so I tend to do a lot of things out there in the community. I'm a mum of a child, a boy, and they come with their own set of problems as well. But as a result, I've got this sort of mixed bag of how I nurse. Okay, so the first thing we want to talk about is I'm going to be very generous. I didn't do a poll in the end because I just thought, oh no, it'd be too complicated for Max. But as I can see from today, it's clear that Max is more than competent to set up a poll if I needed to. But what we're going to look at is Sarah. So Sarah's a 27-year-old woman who has fallen off her bike. She comes into via A&E via an ambulance. So there's, she's obviously been looked after by our paramedic colleagues at the scene. She's complaining of pain in her leg. She has a number of different cuts over her body, and I'm sure there's some of you even on this work experience day that have fallen off a bike and you hurt and are cut in places that you didn't realise you could cut and hurt. And she's got a number of cuts and they're still visible and still bleeding, and she's really, really tearful. So what would you do first, and what would be your priorities? So what would you do for this person? So she's come into A&E. What's the first thing you're going to do for that person? What do you think? You can pop it in the chat. We'll pick those up. Absolutely. Reassurance. Yeah, excellent. I'm really pleased by that, because actually one of the things to look after for someone, you could be doing lots of clinical things like checking her airway, and we're going to go through that shortly. But actually the reassurance will be so important. Calm down, be sure that she's okay and she will be helped. So yeah, you're excellent. All got gold stars. So fantastic. So it's her emotional well-being, and you can't tell her to calm down. All you can do is offer reassurance. The person calms themselves down. So what we're going to do is have a look and go to Najma, you have got the biggest. You can have 2 gold stars for that. We are going to go through the A2E assessment and look at that. It's like as if you knew what was on the next slide. So you're right, reassurance and communication actually come first in everything we do. They're done simultaneously to things, even though we are going to go through the A2E assessment, and that's what we're going to go through. I like to give everybody a bit of learning for the afternoon. So we are going to go through the A2E assessment. Apologies, Alex, I've done a different thing to you. So we're also going to look at vital signs, and we'll talk about your pulse this afternoon. So that's what we're going to do. We're going to think about controlling her bleeding. Okay, because we go through a systematic approach for our patients. Now, it's really important we go through the A2E assessment, because actually we look at the priorities for that person to sustain life in a systematic way, because there's no point in me looking at her wounds if she's not breathing. And I know that sounds quite coarse to you guys, but it's really important that we actually systematically look after a person who potentially could have life-threatening illnesses or conditions or injuries. We will do their vital signs as part of that assessment. So things like the pulse and the blood pressure, how fast they're breathing, what their breathing's like, whether it's going in and out at a regular rate, whether it's noisy, whether it's silent. Because actually we don't think about breathing. It's an unconscious thing we do. And the only reason you've now, in the last sort of 5 seconds, become conscious of your breathing is because I mentioned it. And I'm sure most of you are sitting here going, And it's just one of those things. But when someone is in a state of ill health, it's important that we look at how someone's breathing, because it can be a sign of lots of different conditions. Especially in this situation, it can be an indication that she's bleeding more internally, and also just because she's frightened will increase her respiratory rate as well. So we look at things like temperature and the oxygen levels. Where our priority is also to control any bleeding, we want to promote her comfort. Now, the reason I've used this case study is because, you know, I remember this patient very, very well, and I'll tell you a little bit more about her at the end. But one of the most important things is to promote someone's comfort, because actually once we've got that person stable, it is my number one priority to make sure people are comfortable, because it actually then helps their reassurance and their communication. We obviously want to look at an X-ray for anything that she looks after. And we also want to look after any hidden injuries. Now, the thing is, when people have sustained things like falling off a bike, or in, you know, road traffic collisions, car accidents, or any injury of any sort, any fall or anything like that, we can also have hidden injuries. And we're not just talking about sort of broken bones, we're thinking about bleeding internally, because we can't always see everybody's injuries. And that's one of the reasons why communication is really important with patients, because it's what they tell about. So if they say, oh, I'm a bit uncomfortable in my abdomen, in my tummy, that actually is an indication to me that something might be going on inside the tummy, but I can't see inside it. I can't do anything about it, but it gives me an indication there might be something more going on. So it's really important that we listen to patients so that we can have these look for hidden injuries. And this was particularly relevant for this patient in our care. We need to make sure also, we talked a lot about this morning about the degree, didn't I? I said about it carries the more people that are educated as degree leveled registered nurses, there is a decrease in the mortality rate. There's actually a direct correlation between that. And it's important that we have competence. So as nurses, we make sure we're competent for what we do. We don't go in thinking we can do something and then realise, actually, I don't know that, but I don't want to tell anyone I don't know that. It's really important to actually put our hands up and say, I don't understand that, and I can't do this for you right now, but I'm going to find someone that can. And that's really, really important, that none of us, you know, Alex and I would never launch into something that we don't understand or we're not confident and competent to do, because it's dangerous and affects our patient safety. So next slide, please, Max. I do feel like Professor Chris Whitty. So I said I'd talk to you about our A2E assessment. Now, some of you may have done this if you've got first aid qualifications, because they do cover some elements of the A2E assessment. So we said there about the airway. We would check the patency of someone's airway, because obviously if someone hasn't got an airway, it means that there's no air going to get in and out of their lungs to allow them to breathe. If we don't get enough air into our lungs, so the person receives oxygen, they will not be able to have their tissues, their organs actually having adequate amounts of oxygen and nutrients to allow them to survive. So it's really important that that airway is first. We're looking at if the airway is clear, is it obstructed, can air still pass through? And then sometimes we can hear sort of people having partial obstructions to their airways, and they have a really high-pitched sort of sound that comes out, and it sounds blocked. So it's important that, you know, we do a little bit of that first. Most of our patients that come in, especially with Sarah, for example, it was very clear she had an airway, because she was able to tell us that she was talking to us because she was anxious, she was distressed, and she was tearful. So it was very obvious to us as nurses that she did have a patent airway. Obviously, if someone is silent, if you know, she had come off of her bike and there was no sign of, you know, she wasn't tearful, wasn't crying, wasn't screaming, a silent patient is always very worrying, because actually we want to check the airway, we want to check if the patient's breathing, making sure there's a rise and fall of the chest, making sure if it's regular or irregular. And sometimes that would be hard, and especially in this patient, it was quite hard to see that, how normal it was, because she was so distressed, and you couldn't actually do a full assessment because she was so distressed. Okay, so it was really important that we try to reassure her so we could carry on with this assessment. We check someone's circulation, we check a patient's heartbeat or pulse. Can we feel it? So is it palpable? Is it regular or fast or slow? You know, we look to see if someone's got any tinges of blue, because if someone has an irregular heartbeat or a pulse, or they are blue in colour, it can tell us there's not enough oxygen going around that person's body. And it's a really quick way of us assessing that there's something going on with that person. So thinking about what I've just said about hidden injuries, if someone was bleeding internally, their heart rate would go up. Okay, and that's the same as if Alex had a woman in childbirth who had lost a lot of blood. If someone loses a lot of blood, whether that's externally or internally, their pulse rate will go up in a desperate bid for the heart to compensate, to see if it makes sure that all the other organs are getting enough nutrients and oxygen to allow them to carry on functioning. The heart will beat faster. Okay, now we think about our patient, her heart was probably beating faster because she was anxious as well. So it was very difficult for us to ascertain sort of exactly what was going on for this person. Obviously, if someone's blue tinged, that's telling us that oxygen isn't getting to their peripheries, the outside of their body. So it was really important for us to have a look at the circulation, the disability, check is that someone's ability to move, can they move normally? Now with this case, the person couldn't move normally. She was able to communicate, etc., but she wasn't able to her disability, she couldn't move all her limbs because she had an injury. Okay, and then we can expose that injury to see what else is going on, see if there's any visible fractures, assess the wounds, edema, so swollen discolorations, etc. So it just gives you an idea of everything we do, although we are looking at reassurance, that communication, that care to make sure they're comfortable. At the same time, we are still checking those vital signs of the human body, because actually people are injured, and that's the difference probably between a lot of Alex's care and a lot of the care that a nurse provides. Is the majority of nursing that you'll see in a hospital environment will be ill people, whereas in the community you've got ill people plus health promotion, where Alex, pregnancy is normal. And that's the thing, is we've got to realise is that's why the roles so different, because you know, just it's not, if you are pregnant is a normal part of life, okay, but being knocked off your bike is not normal. Okay, so it makes it very, very different. Do you want to pass to the next slide, Max? I'm going to skip that because of time. Okay, so this was her x-rays following her injury. So obviously I've managed to get that. She had a fracture of her lower limb. I should have put a warning out there, Alex, sorry. I saw her face. This was her injury. So you can see here from the left-hand side that this was an injury. This is her knee going down into her ankle. There is a compound, there's multiple compound fractures there. And she had a significant, you can see the limb is swollen there on the left. You can even see that on an x-ray. And you can see a piece of the bone is actually fractured off of the main bone. So there's a piece of bone that's actually should be in that space by the red arrow, and that should actually be joined up to the rest of the bone. And then that bone itself has been fractured and splintered. Okay, so it's a very convoluted, it's a very difficult fracture that she's sustained. And the only way for us to do that, following her x-ray to be actually found there, would be for that person to actually go down to theatre and have what you can see here. They can actually have metal work put into the leg to stabilise that fracture, because otherwise that fracture will heal, because our bones will automatically try and heal themselves. They will, you know, our bones do heal, as we know. So what would end up happening is that bone there on the left would actually sort of essentially knit together in the wrong places, and that person therefore would have issues with their, you know, movement, their mobility. You know, if you can imagine, if this person walks for a living or does anything on their legs, their career, their employment will be limited. So it's important for us to get the right treatment. So this patient actually went down to theatre and had an open reduction and internal fixation, which means that the metalwork is put into the limb to stabilise that. Okay, so the next slide there. So I was going to say, I thought there was another slide in there, sorry. So it's important with this lady, she did do really, really well. There was no other hidden injuries or anything like that, but it's something we need to think about, is it wasn't just about her leg. Obviously, that was why she was needed all that reassurance, that's why she was upset, but it was actually this leg. And the thing about this individual is she was actually a PE teacher, and I remember her very, very well. And the reason she was so upset was because she realised that she'd had such a catastrophic injury, and it's going to impact every aspect of her life. You know, she was a PE teacher, you know, relatively young, new in her post. She'd only been in the post a couple of years, really aspiring to do what she's going to do, and her, let alone obviously being fallen off of her bike, but she was actually, you know, really, really worried. Her focus was her career and getting on with life. Or sometimes we as nurses have to remember there's another person outside of that person that's in our care at that bed at that time. And that's really, really important, and those conversations are important to them. I often think of people that we look after as well that are things like self-employed, having those conversations when someone is unwell and they're self-employed. They're worried about, especially in the climate at the moment, they're worried about, you know, where am I going to get money for to feed my family? How am I going to pay my mortgage? And that in the subway, I can't pay their mortgage as a nurse. But what we can do is signpost them to those charities, those means. We can refer people to social workers to see if we can support them in some way, helping their families. So we act as that sort of pin, that sort of linchpin in the centre of someone's care. So to you, it might be, you know, you might see it on casualty as a broken leg, but to us, that is a completely different. It's about that extended family, those extended issues around just that person that's fallen off their bike. Okay, so I've got another case study. I've got 2 minutes. We'll whistle through it. Is that all right? And it's the sort of the other end of the spectrum. This is Bashir. He's a 72-year-old man. He was married. He came into a ward following a stroke. About 4 days, I met him after he'd had a stroke. About 4 days. So I'm not going to ask too much about our role in caring for Bashir, but it was really important. So a stroke. Oh, why have I just tried to move the slide myself? Max, could you please the slide for me, please? One of the things about Bashir, which is very, very difficult, is our whole tact was completely different. So he was, in my view, not to you guys, his age is actually relatively young. We are seeing people that are still working into their 70s. And this gentleman had only recently retired, and he had been had suffered a stroke. So for him, one of our immediate things is about, we had taken away, you know, we talked about earlier about the person that makes him him, you know, that thing that makes you the person you are. And it was really important to him that he wanted to function in society. He'd recently retired. He wanted to go out and do things with his life that he hadn't been able to because he's working. He was an active grandparent. So he was married. So it was really, really important. He still had a function in life as a, you know, just because he was retired and we see it as being in his 70s, that person, and especially in these situations, that's young, okay, nowadays. And what happened when he came into hospital, a lot of his these normal functions that all of us in this today take for granted, things like washing your own face, being able to go to the toilet independently, being able to make choices about what you want to eat. So Bashir needed all personal care. He needed to be supported for washing and dressing. He needed to have his elimination needs. He needed someone to assist him to go to the toilet. We need to support Bashir in maybe learning how to walk again because he had a weakness down one side of his body. We needed to do the health monitoring for his vital signs because he'd had a stroke. It is likely that he could have had high blood pressure. He may, you know, have not even known about it. So it's actually educating sometimes people in their cardiovascular health is part of our role. Lots of support and reassurance, administering medications. But the difference with Bashir is we've got to try and get him to still function as the person that he aspired to be in retirement. And that would mean things like referral to speech and language therapists. And now that isn't just for speaking. Bashir did need a lot of support with learning to speak, and he did manage it. But it was when he first had his stroke, he was unable to eat the foods that he wanted. He needed to have certain foods. He couldn't actually have very hard foods and things like that. So you know, we've all got the thing that we like eating. I love an Indian takeaway. That is my go-to thing. That's what makes, you know, the thing I enjoy. But if that was me and I'd had a stroke and I couldn't eat large lumps, and rice is one of the worst things sometimes to choke on, that might be significantly challenging for Bashir and actually could contribute to his health and well-being. It would make him, you know, feel worse. So that referral to speech and language therapists would have been really important. Physiotherapists, occupational therapists, so all these collaboration, remember I said at the beginning, that collaboration between all these different professionals, just to keep our care at the heart of Bashir and not at the heart of ourselves, about what we think that he needs. Yes, we contribute that because of our training, but it's about what we can do and the other collaboration between all the health professionals that can make us care for Bashir. Next slide, please. So one of the things I have to do is, obviously, I wanted to just alert you. Most of you might have seen this on television. The fast, when you suspect someone is having a stroke, I use every opportunity to educate people. For that, I apologise to you all, including Max. So if anyone is having it, you suspect anyone to have a stroke, it's really quick. Okay, it's important to act fast. So when a face has fallen on one side, one arm, can they raise their arm? Is their speech slurred, or you can see they're trying to get their words out and they can't? They're the three indicators that is an indication that someone has a neurological deficit and more likely in this in society now to have experienced a stroke. And it's really, really important that we take notice of that time, because it is time to call 999 to get some support, because we have moved so much forward with research that we are able to avoid people becoming much more disabled following stroke, and we can reverse some of those symptoms. Okay, so I've got another slide at all. No, that's all. I know Amy covered that this morning. So that was our nursing care pathway. So what we want to do is, you've got some questions. Has anyone got any questions at all?
Start thinking about the questions we've got, because we are entering the Q&A panel, so not just for Tash, but that pathway thing, we're going to go over it during this panel as well, Tash, because we need to re-go over the university routes. We want to go over the apprenticeship routes. We want to go over everything. And there's going to be lots of questions that come through anyway. So let's see what questions are coming to the chat box. Let's have a look. Give me 1 second. What I'm going to do is I'm actually going to spotlight all of the speakers that we had, so that we can see them all. And Isabella's coming with the first question. Whilst we do that, are British nursing qualifications valid in other countries if we wish to live and work elsewhere? Why you'd want to leave the UK, I don't know, especially with the beaches and the summers we have. Why would you want to leave? But no, genuine question. Are British nursing qualifications valid in other countries if we wish to live and work elsewhere? Who is going to be able to answer that one whilst I start spotlighting people? Go for it, Tash.
Okay, so British nursing qualification depends what country you are going to. There are certain countries like I think it's Canada, where you would have to do extra exams and things like that. There's certain countries where although the qualification is recognised that you're a registered nurse, there is additional aspects depending on what country you go to, depending on whether you need to do an entrance exam or a top up of some sort. But on the whole, your actual qualification stands across the world. It's just what you might have to do a little bit of something in certain countries to make sure that you're able to work in that country. So for example, I know from Australia, you don't have to do anything. Your nursing qualification is completely transferable. I worked in Cyprus. I was able to work in Cyprus as a nurse. That was a big eye-opener to me, because I nursed in Cyprus when I was in my early 20s for a little while, and it was quite interesting because the registered nurses and didn't have healthcare assistants at all, and relatives used to come in and wash all the patients, so you just did the clinical, which felt very uncomfortable to me, but that was just the nature of the culture of which I was nursing, so I didn't need anything to go and work out there. So it depends on what countries, but it's one of the most transferable qualifications you'll ever had. And Alex, I don't know if it's similar for midwifery as well.
Yeah, so definitely Australia, they really want midwives and they're happy with the qualifications we have over here. So I've got a few colleagues who have gone over and worked in Australia and they get their visas really easily, which isn't great, but I've heard the cost of living is really high up there. So maybe just stay here. No, but a lot, I think America, it's tricky because they're more obstetric nurses rather than midwives over there. The role of the midwife is very different in America. But yeah, it is seen as a positive and beneficial qualification to have across the world.
And one of the things that I always say is that it's a very valid question to ask, but you've got to remember you need to ask the country you want to go to, because it's not us over here that decides which countries will approve what we teach. It's those countries that decide what they approve from elsewhere in the world when you go into those countries. So have a look at what they say as well, because each country is going to be different. But we are I would like to say we're an advantage. I think this is my opinion. In fact, that the standard and the quality of teaching and qualifications that are offered in this country are very high across the world, and we are a lot of people look up to us, so we're in a good position to learn here. But if you do go away, don't forget to come back as well. Okay, right, we've got lots more questions. Welcome back. I will give a quick welcome back to, we've got, obviously you've heard from Alex and Tash. Rebecca is back, Amy is back, Ellie, you're back. I know that Ellie, I think you're back until 2:40. John is back as well. So remember, we met these people all earlier. Let's get the questions in that we've got. So what are the steps on applying for a nursing apprenticeship after A-levels? Amy, is that your area? Well, anybody can jump in, but what are the steps for applying for a nursing apprenticeship after A-levels? Hit us with it.
So the first step would be to actually apply as a healthcare support worker. Once you've got 6 months experience as a healthcare support worker, you can then apply for the level 3 or the level 5 nursing associate or senior healthcare assistant, I think it's called now. I've lost it, but yeah. So it would be first getting that 6 months experience behind you in that role, and then you could apply the application through our trust through the completing an application form and ensuring it's signed by your manager, because you do need to have manager support for an apprenticeship.
Okay, brilliant. And also with that, what I will add is that remember at Pathway CTM, we always work to make sure that opportunities are available on our website, and my job to support students is this as well. But there are resources out there. Go and have a look at the NHS website and look at the job section where you will find apprenticeships advertised across different areas. Also go onto the government website and always go and look at the apprenticeship opportunities on the government website, and you can find more information about what you need to get those applications in, and you can come to my sessions as well, which is great. Alex, I think there's a question for you, and Ellie as well. I think this is a question for you too. What are the cons of midwifery? Let alone the pros. Let's go straight for the cons.
Yeah, let's go to the negatives. So I would say the cons at the moment are vacancies, and this will be across every healthcare profession at the moment. The NHS is looking for more staff, so sometimes you will be on shift where ideally there should be more midwives, and it's a struggle to get all of your break, but I'm being realistic here. You're on your feet for a lot of the time, but actually that's a good thing because your days go really quick, you know, and if you're interested in having a flexible work-life balance, I think you get that because you can either do 5 short shifts a week, so you get 2 days off, or within midwifery, a lot of people do 3 long days. So you think, oh, they're 12-hour days, but actually it means you get 4 days off. So the cons come with the pros. They're individual to everyone. So what works for someone as a 5-day week doesn't work for someone who wants more time off.
And also just to clarify, when you say the cons of the vacancies, that means that there's a lot of vacancies, right? Because you need more people. So actually, for you, that's a con, but for students, that's a pro, because when you're looking to get into these areas, what you need to understand is that there are opportunities. This isn't, we looked at this yesterday, this isn't a dead-end sector, this isn't a dead-end job, this is a sector with lots of opportunities and lots more happening. We touched upon yesterday the fact that the NHS is the 5th largest employer in the world. We looked at social care yesterday and we saw that there's more people employed in social care across a few different companies than there are in the NHS, but the NHS is the 5th largest employer in the world. Okay, I think the Chinese army is bigger, but it gives you an idea of what's available, and we need more and more people. And Eddie, from your side, what you do in the midwifery department, what would you say the cons are?
I think one of the hardest parts of our job, and probably the nursing jobs in general, is dealing with bereavement and looking after families who lose babies. I think it's difficult when anyone dies, but when it's a baby, it really does hit everybody. We have a lot of support around that area, so everybody, you know, you will come across it, but there's lots of support available to you in looking after those families. That's one of the hard bits, I think.
Okay, Tash, I can see you need to leave us, but thank you so much for all of your time and everything.
That's right, no worries. Take care. Bye.
Thank you. Bye bye. Okay.
Bye.
Question.
Bye, Tony.
How many patients do you attend to daily? And would you say in this day and age, with the cost of living going up, would it still be worth being a nurse or midwife with your wages? That's a very honest question. But in terms of patients do you attend to daily, I'm going to start with John, because you're an A&E. What's that like? Is it, I mean, what do you get? 10 patients, 20 patients, 100? Does it fluctuate? What makes a difference apart from Friday and Saturday when we all go out drinking?
It fluctuates a lot, to be fair, but A&E and wards are very different. So it depends what pathway you want to go through. So when I was a student on the wards, and this was at Queen's Hospital, they could have a ratio of 1 to 10, 1 to 11. I think on the wards at Basildon, where I work now, it's usually 1 to 8. It just depends on what areas you work in. So in A&E, you could see anywhere between, I would say, 10 to 50 yourself on a shift, and this is like a 12.5-hour shift, potentially more. But then if you're working in an area like a resus department or ITU, it'll be more like 1 to 1, 1 to 2 nursing. So it does really fluctuate a lot, to be fair. So yeah, it's not really as straight of an answer until you know where you sort of, you know, what areas you want to work in. And then with the cost of living, did you want me to answer that one as well, Will?
Yeah, go for it, please, if you don't mind.
It's not a lie that the wage isn't as good as other places that it could be. And I understand that the cost of living is quite, like, it causes a lot of anxiety along people. But I think within the NHS, it's definitely more about sort of your progression, your own personal development. So as qualified nurses, you need to do something called revalidation every 3 years, which looks at your professional CPD, which is continuous professional development. And the NHS is really good because they will provide you that, and it's pretty much free of charge 9 times out of 10. And so that will help you with that. Whereas I know a lot of private companies, they don't put you on training courses, anything like that. There's additional cost to you. So there's the pros and cons with that. Yeah, the wage is less, but generally you'll get more within your own development out of the NHS.
Brilliant.
Yeah, I completely agree. I don't think it all just comes down to salary. The pension within the NHS is up there as one of the best. Education, just like John's mentioned, and also maternity leave. If you look at some private firms, you don't get any maternity leave. If you think at some point you want to have a family, I know when I had my children, I got full pay for 6 months, and then you get your statutory, then it was half pay for, you know, you got to look into it. But actually the benefits of working for a larger organisation sometimes isn't just on pay. I've just done some quick calculations, and if you're a middle band 6, which is, you know, between 2 and 5 years, so that's midwives, and I know nursing is slightly different. Your take home after tax, obviously this is going to be different for everyone, but it's sitting around £2,200. That doesn't include any weekend or night work, and you obviously always get incentives for those, so you will get an added enhanced rate on top of that. So you've got to look at what your income is for your you know, your situation. But I do think nowadays you do have to think about what pension and whether your next course is going to get funded, or your maternity leave and things like that. I do think you have to factor that into it as well.
Sorry, just to add as well, like, I know this isn't something that people should rely on, but sick pay as well. Private organisations do not pay you sick pay. Even if you were injured at work, they will not pay you sick pay. Whereas in the NHS, obviously there is sick pay, there is sort of policies in place over how much you get depending on how long you've worked there, but it is knowing that that is there should you need it, which is quite reassuring. So yeah, it's the bigger picture really.
And
Really
if it
important information. Go for it, John.
with you, when I started off, so in nursing, you start off as a band 5, and as someone doing shift works, you know, you get more for weekends, nights, and things like that. I could say my take home was, and it fluctuates, but it was anywhere between 17 to 1900 a month, and that is from when you're newly qualified as a band 5.
That's good to know, and it's good to understand these things. I know there are students, and some of you are, you know, year 10, year 11, and you might be thinking, is this really relevant for me? Well, actually, it is, because we always go back. Okay, I've got the advantage of I'm quite old now, and I can look back and go, I started my pension 20 years too late. Do I wish I'd started it earlier? Yes. When everybody told me I should have started it, and I said, no, I'm too young. Was I silly? Yes, I was. But the point is that when you work for an organization that will give you a great pension, it means that you can enjoy the rest of the end of days, the later years earlier, rather than waiting to go to 68 or whatever. So do think about these things and understand the bigger picture. And this is why I always say, do your research and come and ask these questions as well, because it's not just how much do you get paid now today, because even at a young age, if you're 18 and you go onto an apprenticeship and you're getting decent money, if you're taking home £1,500 a month, after tax, and you live at home, that's really good. You know, that's really, really good. So think about these things, and then where is it going to take you further down the line? But use our support if you want to understand these things better, because it can be a little bit confusing. But listen to what people are saying as well. Okay, then Ellie, what about in terms of your role, numbers of patients? What do we look like? Okay, I'm going to ask a blunt question. I'm a man. I don't have children. I have no idea about these things. So in your department, like, what do you see? Like, how many people give birth in a year in where you work? I
think the stats for Broomfield Hospital last year were 5,000 births.
Oh, wow.
I think we had. So we have.
Wow.
Again, it depends which ward. So on labour ward, the midwives will work one-to-one with their patients when they're actually in labour. As maternity care assistants, it's a bit different because we cover the whole ward. So there's 15 labour beds on labour ward, so we would cover all of those. On postnatal ward, there's 20 beds, and then obviously 20 babies, maybe even more if there's twins. So that's kind of 40 plus patients you're looking after on a daily basis. In the antenatal clinics, we have kind of average about 25 people booked in for every clinic. So that's 1 in the morning, 1 in the afternoon. So it's busy. We see a lot of people.
I had no idea the numbers were going to be that high, but again, I don't know. I've never been around this area, so I don't know too much about it. Okay, hopefully other people might have had a better idea than me. Rebecca, when we look at learning disability nursing again, so what's your numbers like? What is your day-to-day like? It's obviously going to be different, but how?
So under the Midwest Essex Learning Disability team, I think we have about 720 roughly, like people open to our services. But again, that encompasses psychiatry, psychology, community nursing and enhanced support. Under enhanced support, because obviously we are a smaller team dealing specifically with more intense work, I think we only have about 27 people open to our caseload. But it can vary over how many people you see during the day. You might go see 2 or 3 people, depending. But if somebody's in a situation where they're in crisis, you might end up spending all day with them, trying to help keep them safe, calm them down, liaising with perhaps psychiatry and people to make sure there's social care, to make sure there's things in place to keep everyone safe. For whenever you do finish your shift, because our service works 8 till 8, Monday to Friday. So at 8 o'clock, we're then handing over care to someone's family and things. So it can be quite difficult making sure that you feel safe, that there's people to hand over to, but that's the nature of the job, unfortunately. But yeah, so it does vary. But yeah, I wouldn't go visit to visit generally all day, because by the time you've got to write all your notes and things, you can't spend all day out on the road. Fair
enough. Okay, good. So we're starting to build a good picture here. Emily has put a question in the chat box, and actually it's more about advice. And Alex, although you've answered in the chat box, the question was, I've asked multiple people and received different responses. Is it best to mention that I want to end up working in palliative care in my personal statement, or should I just speak about nursing in general? I will agree with what Alex says, but Alex, give an explanation as to what you said. And if anybody else wants to offer an opinion, go for it.
So I think that we all hold our own story, our own background, our own preferences. And if you know where you want to go, I think it's important to tell someone what your aspirations are. On a personal statement, I wouldn't solely base it around one topic, but I would maybe loosely link it to that. And if you're ever doing a personal statement for anything, I would try and show them what transferable skills you have. So if you can give them an example of when you've done active listening, communicating to a variety of different people, putting yourself out there, you know, relating to people. I just think there's one of the best things you could do when you're applying for any course is just saying what skills you already hold that would demonstrate you'd be great at that job. So demonstrating care, compassion, listening, communication, I'd say they're your key ones, whether it's midwifery or nursing that you're going into.
Anybody else want to offer an opinion on that?
I completely agree, to be fair. I think I know when I done my personal statement to go into it, I didn't base it solely around sort of one area. And I know, I don't think it's the same for midwifery, how it works, but in nursing, when you are a student, you'll be placed in different areas. So I had medical, surgical, A&E, I done neurosurgical, I done endocrine. So there's so many different variety of wards you're going to be in, that solely basing it on one area might not be a massive selling point, but it doesn't mean that when you come to the point of qualifying, you can't look at working in that area, because you will have a variety of different places to go, which might be a good thing, because you might actually realise that there's somewhere else you might end up wanting to work. But it's about the transferable skills that you already have that you can bring to it. And nursing isn't just about wanting to help people, though it is the main bulk, but it's also about your communication skills, it's about your resilience. There's a lot more to it than people sort of think. So yeah, I agree with it, that completely.
Brilliant. Okay. I mean, I would agree. And if you know what your passion is, and speak about it and go for it, because that's what will ultimately, when people say what you're passionate about and you speak about it, it comes out and it comes across. Okay. John, I'll ask you this to begin with. How do you cope in the winter months where there are more people being rushed into hospital due to the weather? But then on the flip side, does that also happen in the summer because of the heat that we just had that is not normal?
No, there is common. There's something called winter pressures, which is very common in the NHS, and it is true. The numbers increase, the workload increases. I'll be honest, at the moment, the way that it is, it feels like it's constantly winter, and we don't know if that's a backlog from COVID or whatever else, but the numbers are just sky high at the moment. Just to give you sort of a fact, we had not that long ago the most amount of people that come through A&E, which was 527 within a 24-hour period. So the numbers are increasing a lot. How do we cope? In my A&E, we just sort of deal with it, and I can't really give you too much advice. We get on with it, we support each other, we work with each other. The actual department itself, I won't lie, it doesn't always cope. It's always backlog. I think our main thing is just the capacity issue, which I think I mentioned earlier. But personally, I think where we work as a team, we support each other during that. But it's also important for you, for your own mental health, I suppose, really, just to, relax after a shift. You can pick up additional hours, because I know people do, but it's just not to burn yourself out, and just sort of rely on not just support at work, but also support at home that you might have. I'm quite go out with my mates and be quite social. So on my off days, I'll do that, and it takes me away from work. And I think it's quite important that you switch off. And it doesn't always happen, first of all, when you qualify, switching off from work, not just about winter pressures, but about anything. And it's something you will learn to do. And it is really important to be able to switch off from work after you finish, especially in a busy environment.
Great advice. And notice that word that we've been hearing a lot of today, which is support, and the teamwork and the support that you give to each other, which really helps. Now, Amy, what about in your area? Do you have the same pressures in terms of winter, or is it different?
So I actually started in NHS in January, so I missed the main winter pressures, but we do get that too. So just supporting training, getting people onto programs through that time, and making sure that everyone in the department's got the support that they need. before I was working in the university, so working with nurses to support with their training. But again, it was giving that support to the nurses through from the training side of things.
Brilliant, fantastic. And Ellie, what about in your department? I mean, do the colder months make more births, or is it kind of stable across the year?
It's pretty stable across the year. There used to be kind of peaks. Everybody would always say book your holiday in September because all the Christmas, New Year babies would arrive in September, and it would be absolutely crazy. But now it feels like it's just crazy all the time. I don't know if it's because of lockdown, and I don't know, people have just decided to have more children, but it just feels like there are so many babies coming.
Yeah, I completely agree. We used to see in my local organisation, September, October, people would have a good time at Christmas and New Year, and that's when babies would come. Also, some people would want to try and have babies at the start of the school year. But now people have, especially during lockdown, people are spending a lot of time at home with their loved ones, shall we say, and yeah.
Not watching enough
I'd say busier shifts within maternity is nighttime. Often babies are born more at night because the hormone levels for contractions are higher overnight. So if you needed to get catches, or you were thinking about having a busier night shift, generally speaking, it's overnight rather than a day.
Didn't know that. Interesting. Okay. What the tradition? Somebody else asked, what traditional day shift hours for a nurse? Is it 3 12-hour shifts, typically from 7 a.m. to 7 p.m.? Is it different? I'm guessing all of you might have different shift patterns. John, you're nodding your head.
Yeah, inpatient and, any sort of hospitals, usually between the 12 to 13-hour shifts. So we do 12.5-hour shifts. Usually it's 7:30 to 8, 8 to 8:30. I do 7:45 to 8:15. But then we also used to do, they don't do them anymore, twilight shifts. So I used to do a 1:30 till 2 a.m., a 12 p.m. to 12:30 a.m. And then our night shifts are 7:45 p.m. till 8:15 a.m. So that's generally what they do. But I know in community it's different. They do long hours still, because they can work from like 8 till 10, but sometimes they do like traditional 7.5-hour shifts. So it is quite varied, but generally in ward environments, inpatient, it is long days, and it's 3 a week. And then you usually do a fourth one every 4 to 5 weeks to make up the hours, because you're employed 37.5 hours a week full time. But the 3 days it works out, I think it's 34.5 hours a week. So you do an additional one to make up the hours.
Okay, interesting. Okay. I've got another question for you whilst we're on you, John, as well. And somebody else may be able to answer this as well. But Sarah's asked that she wants to become a nurse that is in A&E. How many years do you have to study to be able to finish the course and start the job to become an A&E nurse?
So it does depend on the A&E, but a lot of them take you from newly qualified. So once you've done your training, so I've done the 3-year university degree, and then I went straight into A&E from I qualified. I got my PIN on the 24th of September, and I started, I think it's the day before. So I went straight from there. But I know some A&E, so for example, the Royal London is a major trauma centre, and they won't take anyone until they're 2 years qualified and 2 years experience in A&E.
Okay.
But most general hospitals or local hospitals will take you from being qualified. That never used to be the case. I think it only changed fairly recently. But because there's additional sort of things, there's something called a preceptorship when you start, which is like an ongoing support for the first year. So a lot of them, because you have that support, they can take you from when you're first qualified.
Brilliant. Okay. Amy, from because John spoke about doing his degree and then going on, can you do an apprenticeship equivalent to get to become an A&E nurse?
Yeah, so again, it will start from the level 5 training nursing associate. And then once that's a 2-year program, and then once that's completed, it's another 2 years for the top up for nursing. So that would be a 4-year route for the apprenticeship. But you're doing all the learning in lots of different ward areas again, so getting experience in A&E potentially, and then usually you'd have like a role in the area that you call your home ward. But often people would move around once they're qualified, so the option's still there for that.
Brilliant. Okay, fantastic. Ellie and Alex, when you think about the routes in, what do you see as the most common route into your section? What do you think gives you the best advantage, or does it not really matter? Does it change person to person? Ellie, I'm going to ask you first.
It really changes person to person, I would say, because you don't really have to have any formal qualifications to become a maternity care assistant. I think they do look for English and maths GCSE, I believe, but people come from all different backgrounds. If you've had some care experience before, then that really kind of puts you up the list, but really they're just looking for people who are hard workers, resilient, good communicators, willing to learn, and caring, and that's kind of what they're looking for.
Brilliant. Alex, would you echo that?
Yeah, I'd agree. So within midwifery at the moment, the most common way is direct entry, but they're looking into the apprenticeship for midwifery, and I think most units will offer that to their maternity care support workers first. So I would say if you don't want to go for direct entry, then maternity support worker is your way to go. And if you've got your care certificate or NVQ level 3, that really gets you up there as well.
Brilliant. One thing I will say is that for those students that are out there and looking at timescales and how long it might take, don't rush. Takes the time it takes. Don't worry about rushing to get. And I know it's important to get to where you want to go to, but if it takes 1 year extra, it's not a problem, because you're going to be there for a long time, hopefully, and it is a long career ahead of you. And so enjoy the journey and take the years, and don't think you have to rush and be in place within a year or two. Okay, so Rebecca, let's take a couple of steps back. Traditional day shift hours for your type of role, are you similar to these other guys doing like 12-hour shifts, or is it different?
Yeah, it very much varies on where you work, really. So when I first qualified, I worked on inpatient settings, so like mental health hospitals, and in sort of like residential homes and things like that. So they tend to be 12.5-hour shifts there as well. But that's another one of the benefits of working in a community team, is you get better hours. Well, I think that better hours, because they just fit around more. So like the learning disability team at the moment, hours are roughly 9 till 5. My team we do 8 till 4 or 12 till 8, or some people do long days. But yeah, it's a lot more cushy to work in a community team. You get better hours. But I mean, nights and long days and things, you get used to them whenever you do them, and yeah, they're not as bad in the end.
Okay, cool, fantastic. In terms of like, when we think about the roles that we do and what you do, we talked a lot, you know, we can talk about getting a degree or doing an apprenticeship and the courses that you need, the qualifications that you need. We touched upon it earlier, but what else is it that we can do, and how can students evidence that? So, because we know that when students apply to certain opportunities, they will have strengths, they will have skills, but how do they display this? Because students, and rightly so, they will come to me and say, well, how do I put work experience on my CV? I've never done this job. So what do we look for instead? So Alex, if you imagine your department and your role, what sort of things can students say that demonstrates that they've got, I don't know, compassion or teamwork and skills, or things like that? What is it you would look for?
I look, in my matron role, I used to look at applications all the time, and it doesn't have to be just around care. If you told me you were part of a swim team and you were dedicated to your swim team, so that 3 times a week you would get up at 5 o'clock and go and do your swimming practice, and you know that you would follow a certain diet, or you know, so that you had a certain amount of protein, and I don't know anything about swimming, that's quite evident here, isn't it? But do you know what I mean? Find something that you're passionate in, that you're dedicated towards, or talk about, I don't know, when you like to go to car shows or something, and how you talk to everyone who's showing off their stalls, or tell us something about you that makes you stand out, so that you're a person, and that when I'm reading your application, it's a person at the end of it. It's not just someone else who's applied. I want people who are personable, who would fit well within a team, who have communication skills. But you can get communication skills from so many different places. It's not just about being in care, you know. talk about a group that you've run. Did you go, are you part of a scouts team? Are you, you know, there's so many ways to demonstrate teamwork and resilience and dedication. It's not just about care, so think outside the box. I think a lot of work within health and social care is always thinking outside the box, so you've got to start doing that right from when you apply.
Brilliant. John, what about yourself? What would you say? Would you add anything to that?
I think what was really important that was mentioned was communication skills, because communication, especially in the NHS, is still one of the biggest sort of complaints that comes across. So you being able to demonstrate communication skills is really important. And also just being aware of, you know, where you're applying to, what sort of, like, for example, because different universities will cover different boroughs with regards to who you're going to go and work with. So when I trained at Queen's, it was covering Havering, which was, sorry, it was South Bank, which covered Havering, which was Queen's and King George's. And it's just been aware about sort of what sort of diversity that there is going to be in them boroughs and what you could expect to see. And just, yeah, apart from that, I think the main thing is your communication skills, really important.
Fantastic. Rebecca, what would you add?
I think we quite often will ask for like examples of where you might have made a difference to somebody's life, or you've supported someone, like to enable them to achieve something, empower someone. That kind of thing is obviously quite important in our field. So they're the like, maybe additional things we'd ask, as well as so obviously what Alex and John have raised.
Brilliant, thank you. And Amy, when you look at students that you would take on to an apprenticeship or degree apprenticeship, what kind of skills are you looking for there? And the reason why I ask that is because when you if you go to university, okay, you finish let's say you finish at A-levels, you're 18 years old, you go to university, you have the experience, you probably graduate 21, 22 years old. You're already maybe ahead in maturity compared to somebody who's 18 coming out of A-levels and applying to a degree apprenticeship. Is that right, or is that not always true? And what would you look for in somebody who's finished their A-levels coming on to a degree apprenticeship?
So yeah, I'd echo what others have said about teamwork, communication. That's one of the biggest skills. So other examples, maybe like life examples. So if you're caring for like a grandparent or a sibling or a friend, and those sort of examples too, doesn't have to be work related. Also sort of working as a team, teams, sports, what sort of thing you're doing, and projects that you do at school or college can also help with sort of demonstrating that. So yeah, that's what I would add to that.
Perfect, thank you. Ellie, now I'm aware that you've got 1 minute before you have to leave us and move on, but as you are about to go, what would you say to anybody who on this session or watching the recording has an interest in coming into your area and what you're doing or what you do? What would you say to them to get them over the line?
Go for it. I think just have a really strong idea in your mind when you're writing your application of why you want to go into that role. I think that's always a kind of important thing that we would look at for why people want to do the job. But like everybody has a different reason for why they want to come into these roles, but to just have the reason that is your reason. Everybody's reason is valid, but just have that kind of, not just because, there has to be a reason, I'd say.
Okay, brilliant. Thank you.
I'm going to have to go.
Thank you very much for your time today. Really appreciate it. Somebody asked a question earlier in the session, and it was about midwifery, but I'm going to ask it a little bit. I'm going to ask everybody. So the question was, what were the expectations you had of midwifery before you became a midwife, and were they accurate? So Alex, we'll start with you, and then Rebecca, I'm going to ask you. John, I'm going to ask you, not about midwifery, obviously, about your areas. Go on.
So I was concerned that I hadn't had children before I became a midwife. How can someone who's not had a baby before help and support a woman or a pregnant person who's going through pregnancy or labour? That and women, you know, families would say that. They'd be like, "Oh, how many children you've got?" And I had it once where someone turned around and said, "Well, if you've not had a child, how can you be my midwife?" Actually, everything that someone tells me, I then take at face value. I hadn't at that point gone through pregnancy or labour. So actually, if you told me you need more pain relief, I'll get you more pain relief, because what do I know? And actually afterwards, after I've had children and then been a midwife, now I'm a bit like, oh, okay, so I found that bit particularly difficult. You know, you're sailing through it, you're doing amazing. So you can big them up in different ways. So I think with just the way things that I thought I would struggle with or I was a bit concerned about, it was whether I'd had children before. But actually, you don't have to have children before you become a midwife to make you a good midwife.
Brilliant. I hope that's the same with a nurse, because you don't have to have a heart attack to treat somebody who's had a heart attack. Rebecca, what would you say?
I think that I was a bit naive initially. Whenever I went into my training, I thought that it would all be going visiting these nice people in their houses and having a nice cup of tea and everything would be hunky-dory, which I don't know if I've ever actually had that experience as a nurse. I think it was quite eye-opening, realising the different environments, and especially whenever you're working in inpatient mental health wards, it is very different to what you might imagine. It is challenging, like there's no lie there. But I think your training really helps you to, it covers such a variety of things. I mean, I know with learning disability nurses aren't nurses in the same sense as any other nurses in a way. We have completely different skill set, but it's what makes us able to do the job we do, and then to link in with all the other professions, whether it's supporting a pregnant service user with a learning disability to their appointments, or helping them with raising the kid, or taking someone to a general hospital appointment and supporting them to have a procedure which needs all these adjustments being made to facilitate, or supporting people with mental health conditions. Oh my God. My smoke alarm has decided to go off, so I'm going to mute myself.
Okay, you go for it, and I'm going to move on to John and ask him, then I'll come back to Rebecca. Right, John, you went on to be an A&E nurse. You must have had a fairly accurate picture of, you obviously did your research and watched the TV programs that I watched to get a real idea of what goes on. Was it accurate, and what was the reality?
No, it wasn't accurate at all. I had a placement in A&E when I was a student, but prior to actually starting my training, I was a HA, and I wasn't a HA for long. I didn't have any, I think the idea of what I thought was going to happen wasn't reality at all. I thought, oh, I want to work in A&E because you're going to see the really sick people, you know, you're going to be involved in, have someone coming in with like cardiac arrest, traumas every day. And it's not like that at all. It's very much, you can have a wide variety of people coming in for different conditions, but also people needing what we class as like social care needs. So they might just need like more carers, or they might be homeless or something along them lines. I think, again, I was quite naive in what I thought was going to be reality when I started working, not even just in A&E, in nursing in general. I didn't have an awful lot of experience, and I think that was I was a bit worried about that in the first instance, but your training does really help you through that. I feel like someone with, you know, as a healthcare assistant, whether they've had 1 year or 10 years of experience, going on to that additional, to become a qualified nurse is very different. So don't always think you know it all. I think it's really important. And the other thing was the sort of responsibility you have, and the accountability as well. Because we all are, when you're registered with our Nursing Midwifery Council. So if you ever go to uni and speak to other nurses, you'll hear them talking about their PIN. That's their registration, a professional registration. And with that, you have a professional responsibility. And I don't think I've realised how much of a responsibility you would have as a registered nurse, you know, to your patients, to yourself, and just your sort of accountability with that as well. That was something I didn't realise at all until I qualified.
With that then, and when you think, and I'm going to ask the same to you, Rebecca, in a second, we'll come back to you. When you think of that, so you get in there, and it's a little bit different to what you imagine, and what you just said there about the responsibility. Tell us genuinely, how did that feel? Did that scare you? Did it worry you? Did you then think, hang on, what am I doing here? Or was it a case of, yeah, that worries me, but I've got people who are supporting me, and I can actually do this and they're going to help me out?
I think, but I really believe it's sort of the support with the team you have around you, because we're quite lucky in A&E where it's so fast paced and there's a lot going on. There is a lot of support in the sense that you've got people that have been working there for years, ask questions. I will still ask questions, and I think it's really important to not believe you know everything. That's a dangerous mindset, especially in a career where you've got people's lives in your hands. Never be afraid to ask questions, but in the same sense that another team might not have the same sort of set of, you know, morals or whatever. So it's you knowing what you're doing before you're doing it. So obviously we give a lot of medications. That's a prime part of nursing. And for us, our responsibility is knowing what that medication does, how it works, when you shouldn't give it and things like that. And for us to give that medication in an incorrect way would be down to us, and we would be the ones that would be held accountable for it. So it's just making sure that if you have a good support network around you, to use it. If you don't, know your competence and also your scope of practice, and make sure that you don't go above beyond that. I remember when it's a bit different scenario, but I remember I worked in the call centre once, and I remember they done this training with us, and they were like, you should only ever have to ask 2 times about how to do something, and you should know how to do it. And I remember that when I must have been about 19. So when I came into nursing, I thought, was it going to be the same thing? And they were like, no, if you need to ask a question, ask it. You can ask the question 1,000 times. It could be something you haven't done a lot. You might have done once, then the next year you've got to do it again, then you might have to do it in a few months. I think it's really important to be a support if someone asks you a question and you know the answer, but also to get that support when you need to.
Brilliant. Okay, that's good to hear. Rebecca, we'll come back to you. You know, you were saying about it was quite different to what you had imagined. Same question, brutally honest one, and I know it's putting you on the spot, but was there a moment where you thought, hang on a minute, what am I doing here? This is totally different to what I expected. And how did you kind of overcome that?
Yeah, I'm not gonna lie, when I first qualified, I found it really difficult. The environment that I was working in and the responsibility being placed on me. And I found it quite difficult to start with. But there is a lot of support out there, not only within your team, but there's also every organisation has helplines for their employees to call, mental health support, anxiety, even things not related to work. There's helplines for that. I know one of the most difficult things that I've found is about managing that risk and holding the risk for someone else in a situation, and you might be worried, like, is this person still going to be here whenever I come on shift next? Especially in the community when someone might be at home by themselves. And that is quite difficult, but that's why it's so important that we have all the different disciplines around us. So whenever you're making these decisions, like such serious decisions, you're not doing it by yourself. You do have other people around you that are part of that. And even within your team, you've got other nurses, HCAs, anyone else that's about, and then you have your on-call procedures as well. So if you are worried about something, then there is always someone that you can call. Because it can be challenging at times.
Again, it's that same thing again, and I want to reiterate it. Think of that support, that teamwork, the things that you have, the systems that are put in place to make sure that you are looked after, and that you can do your job to the best possible standard. So things are put in place. This has been a lot of great information. Now we've got 10 minutes left, so we're going to do a wrap up, and I'm going to do the thank yous afterwards because everybody is still here. If there are any last minute questions, do put them in the chat box, even though we've had quite a long session. But it's been great to get that information from people who are involved in it, that are doing it every day, and that have been in your shoes and have thought about these things and then experienced what you're about to experience or potentially going to experience in the future. And when we think about today as well, you know, the real important thing to understand is that there is support, there are opportunities, there's a lot of opportunities, and there is a great career available, and there are so many different things that you can do. Just go out and find out about it and get involved. With that, what I want to say is that I'm going to share my screen again because Kate, who helps us put these sessions, well, I say helps us, Kate does a lot of the work to put these sessions together, to get the people involved, to make sure it all runs smoothly, to make sure it happens. I want to introduce Kate briefly because we've got another couple of slides that Kate's going to go through, and these links and this information will be sent out to you so that you can look at it in your own time. But let's get Kate on. Are you here with us? And welcome to the session, although you have been with us.
I am. Hello.
So do you want to take us through the last few bits? Let's do it.
Yeah, so I am a Health and Care Academy coordinator. So I work with the integrated care system that Alex mentioned earlier. And I work within the workforce team. And my role is really about offering people like yourselves an insight into the job roles within NHS and social care. So that is pretty much my whole reason for being. So we have a number of sessions we hold throughout the year, but we also go into schools and colleges where we bring in health professionals like the lovely people we've had today to talk about their job roles. So you get a really good idea of what the job actually involves rather than just trying to read out on the internet and find out information. I don't think I had any idea of how much was involved in being a midwife and working in A&E, and even like learning disability services. Not many people know about learning disability nurses. If you want to find out more information about these job roles, we hold events throughout the year. So go and check out our website. And we also have a little bit of information about job roles and videos from people in those job roles as well that might be of interest. So that's that. I believe you're sharing these slides, aren't you, Max, later on?
We are, yeah.
Yeah. We talked about getting experience. You can get work experience within the hospital setting. You will be fully supported by members of the staff team. It was restricted over the COVID period, but now it's opening up again. So there are sometimes age restrictions in place. So it might be that you have to check that out before you apply. And these placements within the hospital setting could be anything from a few days to a few weeks. So if we go on to the next slide. So if you live in the Mid and South Essex area, if you go and check out their website, they have a page specifically for work experience. I believe it's closed at the moment, but the next work experience applications are opening up in September. But there is an email address there. So if you are interested in work experience and wondering what kind of opportunities are available in Mid and South Essex at the hospitals and throughout the trust, do check out the website and send an email through to the team. They're an amazing team and incredibly supportive. And so they'll give you some guidance. And with the next slide, if you live in the North East Essex area, obviously we have some hospitals. We've got Colchester Hospital, and they also run a variety of kind of work placement opportunities. So again, give them an email, find out what opportunities are available. And then if you go onto the website, you can actually apply via the website. There is an application form. But as everyone has said today, work experience in a hospital or in a trust situation, although it's very valuable, there are many other ways you can get work experience. So it could be that you do some volunteering work for maybe a local residential home. You could work for charities. You could even offer to support an elderly neighbour or elderly relatives. And all these different experience and opportunities help build up your transferable skills, which again, Alex was talking about earlier. So things like your communication skills, problem solving skills, teamwork skills. And equally, you know, working in a part-time job will help you build up those skills. So don't feel that even though you want to go into a medical environment to work in as a career, that your work experience has to be solely within that same environment. For example, if you're working behind the counter at a fast food place, you're dealing with a lot of customers who each have different needs. Some can be quite angry. And so you have to deal with those kind of situations and you build up a lot of skills. So yeah, but if you want to grab some work placements, do check out the websites for opportunities.
Fantastic. Thank you very much for that, Kate. Really valuable advice there about the work experience at the end. And I think we heard that as we went through, didn't we? That people spoke about the fact that those skills can be, let's say, nurtured through different ways. You don't have to be in the medical sector to be able to get into these roles, because at a young age, it can be very difficult to get the work experience. But what other things are you doing? We talked about those other activities that you can do that bring around your teamwork, that bring around your communication skills. And remember, communication skills is both listening and speaking. And some may have one, some have the other, some have both. Not everybody has both, by the way. So think about those things, and then think about your friendship groups and what skills do I have within my friendship group, and how do I display those, and retail and hospitality, those kind of jobs as well, if you can get them, those part-time jobs or whatever, they provide you a lot of skills. They do, because you are still making decisions under pressure, working with teammates, communicating. Yeah, maybe somebody's life is not in your hands at that moment in time, but it's very similar skills, just a different risk level. So think about those things and what you can do. And look, we've heard all the way throughout the day, there's options. There are different options. You can go university route, you can go apprenticeship route, you can go straight into work. Go and do the research like you have done today by coming to today, to then look at what is the right one for me? Where am I going to go to? Ask those questions and try. Just have a try. And if it doesn't work out, or if it's not what you thought it was going to be and you're not happy with it, you can move and try something else. But don't be afraid to make those steps forward and get involved. The resources are there for you to be able to do research. The recording will be available on the website. We will get those links sent out in the emails afterwards, and we will also email you a feedback form to tell us if you need more support and what we can do better. Go and have a look at all those websites that I mentioned. And I will also say that you can go and follow us on the @Pathway CTM handle on TikTok, Instagram, Twitter, LinkedIn, Facebook, but apparently Facebook's for old people because I'm an expert at it. But Instagram and TikTok is where we will display a lot of opportunities that we have, new events, work experience opportunities, job opportunities, apprenticeship opportunities in all of the sectors we work with, and with the things that we've talked about today. So make sure you keep your finger on the pulse and go and follow us. And if you get your certificate today, mention it on the stories and it will help you out as well. So we started the day with a poll, and we started the day with some word clouds, but we're going to finish the day with a poll as well. And I want everybody to get answering on this one. We've got 2 simple questions. It should appear on your screen now. If it doesn't, you might need to press polls at the top. Following today's session, how much more do you know about nursing and midwifery and the routes in? Do you know a whole lot more than I did this morning? Are you practically an expert now, or do you know a little bit more? I think I know a whole lot more than I did this morning, and I definitely have been educated today. And following today's session, what route are you likely to take after leaving school or college? Do you still want to do university? Are you thinking of an apprenticeship? Is it a gap year you're going to look at? Or are you going to go straight into working in nursing or midwifery? Or is it something else? What are we thinking? We're almost there. I'll give you another 30 seconds to get all of those questions answered. We're almost there. Give you another 20 seconds. So following today's session, how much more do you know about nursing and midwifery and the routes in? 10 more seconds, 10 more seconds. Okay, let's share the results. Let's have a look. So following today's session, how much more do you know about nursing and midwifery and the routes in? 83% know a whole lot more than you did this morning, and 10% are practically experts now. 7% know a little bit more, but that 83% phenomenal, and the 10% phenomenal. It means that we've done our jobs today, and all of the speakers that have come along have really passed on great information. And following today's session, what route are you likely to take after leaving school or college? 14% looking at apprenticeship, 76% looking at university. Fantastic. That's brilliant to see. Good to know as well. And when we look at it from this morning, apprenticeship has gone up by a lot of percentages, and I'm not sure yet have come down. So we were at 6% for apprenticeship this morning. We're at 14% now. Brilliant. Okay, let's get rid of that. Thank you to everyone for today. Thank you to all of the speakers. Thank you for coming along and sharing your information, your experiences, and giving up your time as well, because we know it's really, your time is precious, but it's important that we do this for students as well. And thank you to all of the students for interacting, for getting involved. And thank you to Kate as well for putting the day together and getting everybody involved and making it so successful. We really, really appreciate it. Everybody go and enjoy your afternoon. Go and enjoy your summer. This is the last Pathway event of this academic year. We're starting again in September, but there will be things happening in August as well. So keep an eye. But to all of you, thank you for coming along today and sharing all of that information. Really, really appreciate it. And as you can see, there's lots of thank yous in the chat box. So everybody, make sure you enjoy your summer. Go and do those wonderful things. Those of you going to Portugal and Wales, camping and all of that. Fantastic. Thank you.